is for only our speakers. The people will be watching us on other platforms.
नो अभी तक कोई देख नहीं पा रहा है, वो लिंक काम नहीं कर रहा है, यहाँ पे
Actually, the
मैसेज
link
है।
has been given only now. So when I had posted in my groups, there was a query, where is the audience link? I have just posted 20 minutes back.
Sunil, can you answer it?
अभी तक लिंक आया नहीं है मेरे पास, मतलब वो लिंक जो भेजा था टिंकू मैम ने वो काम नहीं कर रहा है।
So we are live.
Okay, we will address that. Sunil is addressing. Okay, good evening, friends, and welcome to this our monthly webinar. And this month we will be having on clinical retinal pearls. So it is basically in our day-to-day practices. We have chosen the topics which are of relevance to the common ophthalmologist even in the periphery. And with that intention, today's uh, particular theme is clinical retina pearls. I'm thankful to our moderator, Dr. Tinku Bali, who is a member ARC North, who is responsible for today's webinar. So without much ado, can I request Dr. Tinku to carry forward the proceedings?
Thank you, Dr. Prashant. So on behalf of AIOS ARC, it's my pleasure to welcome you all to today's webinar on clinical retinal pearls, what every ophthalmologist needs to know. I'm Dr. Tinku Bali, a vitreoretina surgeon at Sir Gangaram Hospital, New Delhi, and I'll be your moderator for this session. Well, as we all know, the retina is an immensely fascinating structure, and it often shows very subtle signs that can make all the difference between early intervention and irreversible loss of vision. Whether it's in general practice or subspecialty care, having a very good grasp of retinal findings and their management is essential for every ophthalmologist. So today's session brings together practical insights, diagnostic tips, and clinical pearls that you can apply to your day-to-day practice. Our galaxy of speakers will take us through common retinal pathologies, their diagnostic pitfalls, and also share very practical tips on how you can manage these conditions. So we'll be covering all the common case scenarios that we see in our practice. We've not included diabetic retinopathy because we've already had a big webinar on that. So we have other common conditions. And I'm extremely thankful to all the speakers and our chairpersons who are with us today. I'm also thankful to the audience that has logged in. Before I introduce our chairpersons, I'll request the audience to make it as interactive as possible. So please keep posting your question either on social media, Facebook, YouTube, or here in the chat box. So with that, I now welcome our chairpersons who've so kindly consented to be here with us this evening. Chairing this session, we have with us Dr. Ajit Babu Majhi, who is the head of the Vitreoretina Services at the Yashoda Group of Hospitals at Hyderabad. A renowned vitreoretina surgeon, educator, and researcher, Dr. Majhi is widely recognized for his clinical expertise, academic contributions, and dedication to training the next generation of ophthalmologists. He's been my teacher also, and I can vouch for the impeccable work that he does. So today we are honored to have him share his vast clinical experience. Thank you, sir. Thank you so much for honoring us with your presence.
It's my pleasure.
And we also have with us Dr. Malika Goyal, who's a senior consultant in the retina, vitreous, and uveitis services at the Apollo Health City, Hyderabad, where she has been instrumental in advancing not only clinical care, but also research. So she's known not only for her expertise in managing complex retinal conditions, but also for her passion in teaching, in research, and mentorship. So we've seen her speaking in so many conferences, and she always has very, very practical tips to give us. So we are delighted to have you, ma'am, and look forward to insights from your very vast clinical experience. Thank you so much for your presence. Thank you. So with that, we dive into the webinar now. And first of all, I'd like to invite Dr. Mudit Tyagi to give his talk. So Dr. Mudit is a prolific vitreoretina surgeon and uvea expert. He's actually the uvea magician. And he is the head of the retina services at the LV Prasad Eye Institute, Hyderabad. So Dr. Mudit will be talking to us about pearls in infectious uveitis. And I'm sure he's going to give us some very, very, very practical tips on when we see these patients in our clinic. So over to you, Doctor.
Yeah, thank you so much. Good evening, everyone. And let me first thank our chairs for this session and also Dr. Tinku Bali and AIUS Scientific Committee for having me here. So are my slides visible? And
Yes.
am I audible?
Yes.
Yeah.
Yes.
Yes, thank you so much. So I will be talking in brief about 10 pearls in infectious uveitis and how a lot of these cases of infectious uveitis can be just diagnosed on the basis of a good clinical evaluation. You do not need too much of extensive laboratory evaluations, don't need to rely on too many laboratory tests. But these are conditions which retina specialists commonly encounter and what all of us should be knowing. And these are clinically identifiable entities. So let me just show you a few of them and how we can go ahead identifying them. So now the first and the foremost rule is that every retinitis is infectious unless proven otherwise. So now that is the first point which we have to remember. Whenever we see our retinitis, the first dictum is to consider it and treat it on lines of infection and rule out infections before labeling it as a non-infectious uveitis, meaning thereby all retinitis should be treated appropriately by their antimicrobials. If steroids have to be given, they need to be given under the cover of an appropriate antimicrobial based on whatever the cause of that infection will be. So that's the first thing to remember. Every retinitis, unless proven otherwise, has to be considered infectious and becomes our duty to find out the cause of the underlying infection. Now comes the second clinical point. A lot of times we see these lesions on the posterior pole or in the retina, and the dilemma is whether are you dealing with a retinitis or a choroiditis, or sometimes other mimic a nodular posterior scleritis. Now, a very easy way to diagnose or differentiate them can be on the basis of an FFA or a fluorescein angiography. And how do you differentiate between them? Now, this is a pearl which has been given to us by one of our uveitis teachers, Dr. Avinash Patange. And this is something which I found very useful and therefore I end up sharing with most people. So look at two things. Number one, the intensity of early hypofluorescence, and number two, the pattern of early hyperfluorescence. So these are the two things: intensity of the early hypo and pattern of the early hyper. And I will show you with example. The intensity of early hypofluorescence is maximum in retinitis, followed by choroiditis and then scleritis. And then the pattern, if it is a perilesional early hyperfluorescence, then it's a retinitis that you are dealing with. If it is intralesional diffuse, then it is choroiditis, and you will see multiple pinpoint leakages in cases of scleritis. And let me just show you how that can be appreciated. So these are three images. On top, you see a retinitis lesion. Now look at the pattern of the early hypo. Look at the intensity of early hypo. The intensity is maximum in retinitis followed by choroiditis. But more importantly, look at the pattern of the early hyperfluorescence. Now, if you look at this, you see a hypo with a perilesional hyperfluorescence, and that is characteristic of a retinitis. Whereas you see a hypo which then diffuses and involves the entire lesional hyperfluorescence, that is what you deal with in choroiditis lesions. So you see basically choroiditis lesions where you will see an early hypo which evolves into a diffuse intralesional hyperfluorescence. Whereas if you see multiple pinpoint leakages, a T sign of B scan, then your diagnosis becomes clear, you are dealing with a posterior scleritis. But the points to remember are intensity of early hypo and pattern of the early hyperfluorescence, and that can help you differentiate basically what is the lesion you are dealing with. The other point is also the clinical examination. If you look at a retinitis lesion, you will realize that the retinitis lesion tends to obscure the underlying blood vessels. Whereas for lesions which are deep, meaning thereby the ones emanating from choroid, you will see a deeper lesion with a blood vessel coursing over it, because obviously as the name suggests, it's from the choroid, it's lifting everything up. So you will see the retinal lesion vessels coursing over the lesion. So if you see that, you are dealing with a deeper lesion, meaning thereby choroiditis. If you see a yellowish lesion which is obscuring the underlying blood vessels, then probably you're dealing with a retinitis. So that's how you clinically differentiate between these two. Now, one more disease which can be very easily identified, and that is something which we are seeing more and more in our clinics these days, and something which a lot of people end up missing. But once you realize how it looks like, it is very difficult to miss. So this is basically a pattern of ocular syphilis. So if you see a patient with a placoid chororetinitis, a placoid lesion in the posterior pole with intense infiltration at the edges. So look over here. You see a lesion which is a chororetinitis, but look at the edges. You see intense infiltration at the edges. You do an OCT, you see an RP nodularity and some photoreceptor damage. Put both of these two together, you are probably dealing with a case of ocular syphilis. And because syphilis is such a big masquerade, we usually recommend getting every treatment naive patient of uveitis to be tested for ocular syphilis because of the fact that it can mimic any entity. And the test to be done is a tryponymal test, first of all, because they've got a higher sensitivity specificity. So get a TPHA done for all of your treatment uveitis cases. Look for VDRL in terms of response to treatment. So get your TPHA and VDRL titers done. A four-fold reduction in VDRL titers essentially means a clinical cure along with resolution of lesions. But to diagnose, remember, get a tryponymal test done, which is a TPHA. These are the other patterns which you look at it. So if you see these multiple small miliary lesions and you do an OCT and find a full thickness retinitis, you may see miliary lesions in these multiple lesions in sarcoid and other disease also. But if you see a lesion and an OCT shows a full thickness retinitis, those lesions are characteristic of syphilis, and a lot of times you will find them in cases which have initially been wrongly treated with steroids alone without an appropriate antimicrobial. So if you see a patient who has initially been wrongly treated with steroids now comes to your clinic with these multiple miliary lesions, think again of syphilis as one of the possible differentials. And a ground glass retinitis with a central clearing. So you see a diffuse, shady, gray, glassy sort of a retinitis with a central area which is clear. Again, a clue to ocular syphilis. So remember, number one, a placoid chororetinitis with intense infiltration at the margins, multiple miliary lesions, and a ground glass retinitis with central clearing. All of these three are very characteristic patterns of ocular syphilis. From syphilis, moving on to one of the most common causes of a unifocal retinitis. Whenever you see a patient with a unifocal retinitis, your first differential should be an ocular toxoplasmosis. Also, what you need to remember is that sometimes you may see a retinitis lesion at the edge of a scar. If you see a retinitis lesion at the edge of a scar, you are nearly sure that you are dealing with a toxoplasma. So toxoplasma lesions recur from the edge of a scar. And a unifocal retinitis, again, the most common differential is a toxoplasma. So whenever you see a unifocal retinitis, think of toxoplasma as one of your differentials. What you also need to remember is that sometimes a retinitis lesion with an intense vitritis, the only two most common differentials, or rather three, will be number one, toxo, that present with an intense vitritis, number two, acute retinal necrosis, and sometimes endophthalmitis. So if you see a patient with a dense vitritis, but through that you are able to see a central unifocal lesion at the posterior pole, your diagnosis nearly becomes clear you are dealing with the toxo. If you see dense vitritis with some lesions in the periphery, confluent lesions in the periphery, ARN, and then third will be an endophthalmitis. Now remember, toxoplasma can also sometimes cause a lesion which may mimic a acute retinal necrosis. But the point to remember is something which I told you some time back. Toxoplasma lesions recur at the edge of a scar. So this was a patient which we saw who was initially thought of as ARN, was treated with antivirals, but the lesions were not regressing. But look at it. You see a scar adjacent to it, and then you see this lesion at the edge of the scar. This was a case of toxoplasma retinitis. We started this patient on anti-toxoplasma treatment and the lesion started regressing. Moving on to one more common cause of a unifocal or sometimes multifocal lesion is a candida endophthalmitis. Now, if you see a patient who has had a history of either being immunocompromised or having undergone any procedure, this was actually a patient who had undergone a hysterectomy before she presented to us. But you see a unifocal large lesion with margins which are probably emanating into the vitreous. You do an OCT through it and you see a lesion protruding into the vitreous, and you are not able to see the area behind it. So a lesion protruding into the vitreous, obscuring the areas beneath it. That's what's called a rain cloud sign. And that usually is also very characteristic of a candida endophthalmitis. Compared to that, aspergillus endophthalmitis is more diffuse, can have areas of hemorrhages. So if you see a subretinal large lesion, that can be a clue to an aspergillus endophthalmitis as compared to unifocal ones, which are characteristic for candida. So deep retinal lesions with horizontal enlargement, sometimes hemorrhagic vasculitis, sub-RP and subretinal space infiltration is characteristic of aspergillus. One more disease which we should keep in mind and which is often another masquerade is a primary intraocular lymphoma. Now, if you see a patient with diffuse retinitis, you see multiple of these yellowish lesions. And remember, these are eyes which may respond to steroid, but the lesion keeps on coming back. So elderly patients with lesions not responding to steroids or recurring back, think of lymphoma as one of your differentials. You may see these dirty yellow lesions with pigmentary changes. The moment you see them, think of lymphoma as one of your differentials, and that is what you should be looking at. You do an FFA, you may see that leopard spot sort of an appearance over here. And when you do an OCT, you see this sub RP infiltration. So yellowish lesions with pigmentary changes, well-defined margins, coming back the moment you discontinue steroids, sub-RP infiltration. All of these pieces put together and the jigsaw puzzle reveals itself. You may possibly be dealing with lymphoma. So this is one more entity you should keep in mind. Now, one more clinical tip. We are talking about essentially masquerades, but do not let them fool you. I know we will be talking about some clinical tips in CSR, but this was again a patient who was diagnosed as an infection and referred to us. But look carefully, you will see a yellow lesion, but in between that, you will see this area of lucidity. So if you see a yellowish sort of a lesion with this lucid central clearing, probably you are dealing with a CSR and not with an infective retinitis, and an OCT will very nicely reveal it to you. So this is what we are talking about. So this basically the CSR with subretinal fibrin. Don't let it fool you. Don't jump into infections. The reason I wanted to show you this is because not every yellow lesion on the posterior pole is not an infection. So keep in mind these differentials. These are all clinically relevant points which you can identify just on the basis of a good clinical examination. And last point is remember the possibility of drug-induced uveitis. If you see a patient with a sudden onset of a hypopion and angle closure, one of the most common differentials will be taking a drug history. And I usually tell everybody it becomes very important for clinicians to take a good meticulous history. Something which has been taught to us from medical school, the importance of a good history. And these are examples which will illustrate it best. We had a patient who was treated as a glaucoma. The moment we asked the patient for a history, that patient was taking topiramate. So hypopion uveitis, sudden angle closures can be a very common manifestation of topiramate induced drug toxicity. Also remember, if you see a patient of on tuberculosis treatment comes to you with a sudden onset of a hypopion, that can be a manifestation of drug toxicity of rifabutin. So ask the patient what is the drug the patient is taking. Anti-uveitis is a dose-dependent side effect of rifabutin. So the point over here is always whenever you see a patient of uveitis, or for that matter any patient that we see in our clinic, it becomes important for us to take a good meticulous drug history. We have had patients who presented with a VKH-like picture, but they were taking JAK kinase inhibitors. So patients taking JAK kinase inhibitors, patients taking anti-chemotherapy agents like nivolumab, all of these can also manifest with a VKH-like picture. So the point and the reason I am telling you this is because we need to remember the importance of taking a good drug history. So these are the clinical points and pearls which I wanted to share with everyone. Thank you so much. I hope you find them useful, and thanks once again to the committee for giving me a chance to share these with you. Thank you.
Thank you, Dr. Mudit. You shared some excellent pearls, very practical, very handy, and you brought out some very important points that are often overlooked. So, just a question that we have in our chat box, that you said that you have to rule out infectious causes before you diagnose a uveitis. So, do you include a battery of tests, any posterior uveitis that you see? Do you go by your clinical findings and then investigate, or do you include all these battery of tests, for syphilis or TB or toxo in your investigations before you start?
So the point is that you have to tailor your investigations based on the clinical presentation. When I said I did not say all uveitis are infective. I said all retinitis. If you see a retinitis, you have to rule out infections. Retinitis usually are always infectious unless proven otherwise. The only common cause of a non-infective retinitis is Behçet's. Rarely sarcoid and TB can also present with retinitis, but that is extremely rare. The common cause of a non-infective retinitis essentially is Behçet's. The other rare one is sarcoid. So the point is retinitis, if you seen in clinic, has to be taken as infective unless proven otherwise. That is in terms of the manifestations. In terms of getting a test done, I again strongly believe that you cannot be getting every test done for every patient. It has to be tailor-made as compared to what you see clinically. The only test that I get done for every single patient of mine are serology for syphilis, because like I said, syphilis is such a big mimic. We have had it presenting like granulomas, as retinitis, as choroiditis, and any form of presentation. And once diagnosed, it becomes such an easy disease to treat because you just need to start them on penicillin and the entire disease goes away. So every single patient who comes to our clinic is actually investigated for syphilis. That's the only other investigation. The only other investigation that I usually get done for all of my patients are serology for HIV. The reason is not because you are suspecting HIV, but you need to start your patients if they are there on long-term steroids or sometimes even immunosuppression. And therefore you need to rule them out. And a complete blood picture. So these are the only 3 tests that I get done for every single patient of mine. But apart from that, the investigations have to be tailored based on the clinical presentation.
Thank you. So I ask the chairpersons if they have any inputs. Dr. Ajit?
Yeah, I would say that CSR, he has shown a OCT picture, but it would have been better that you have, I think, angiography.
Yeah,
That is the best test to prove your clinical picture.
yeah.
That picture, if you have a leak, it's almost proves that it is CSR. It is very commonly encountered clinical picture that you have shown. The second one was the candida infection. If you see the OCT, there is a epiretinal membrane which is extending on to this thing that indicates that it is a little long-lasting infection. So the indolent nature of the clinical presentation itself proves that it's a chronic fungal infection, and more likely the clinical picture shows it is more candida. It's a clinical diagnosis rather than this thing. And in that case, you can take a small sample directly and subject it for microbiology and then treat it accordingly.
Yeah.
The other presentations are very good, and I think we should be short and sweet. So,
Dr. Malika, would you like to add something?
Yeah, very good presentation, Mudita. I've seen it earlier. A couple of points only. One is that the miliary lesions which you showed are, in your experience, syphilis. But I think they indicate any inflammation. So I have seen them with TB also, resolving with ATT. Also, toxoplasma can present as frank endophthalmitis. I think you have seen my case in HRS, where the whole vitreous can be full of exudates and you may treat as endoph only to find that it was toxoplasmosis with a scar at the back. So that is to be kept in mind. Lymphoma can present in young people if they are HIV infected. So it can present as bilateral intermediate uveitis, and then you start seeing subretinal deposits, and it turns out to be HIV patient with lymphoma. And the new tyrosine kinase inhibitors, which are being used in oncology very frequently now, are very often associated with uveitis, vitreous hemorrhage, and a host of ocular problems. So when we see unexplained diseases, conditions in the eyes, we should take a drug history and look for these tyrosine kinase inhibitors.
Exactly. That is the reason why I made that point, that it is such an important thing to take a good meticulous drug history and
Exactly.
ask the patient what are the medicines they are taking.
Exactly. Thank you.
Thank you so much.
Thank you. So with that, we move on to our second talk for the session. And our next speaker is Dr. Chaitra Jaidev, who's a senior consultant in the Retina services at Narayan Nethralaya, Bangalore. She's also a very prolific researcher, and she's the treasurer of VRSI and also the secretary of the Karnataka Ophthalmic Society. So Dr. Chaitra will be speaking to us about how to screen the peripheral retina, how important is it, and which are the lesions that we need to watch out for and treat. So over to you, Dr. Chaitra.
Muted. Chaitra.
Okay. Am I audible now?
yes.
Yeah. Thank you, Tinku and Dr. Prashant and the entire team, ARC and AIOS for this opportunity. I'll be speaking on the importance of screening the peripheral retina. We all know how extremely important it is and how very significant lesions tend to get missed when we just look at the posterior pole. I'm not going to the details of all the systemic diseases, and particularly as Dr. Tinku mentioned, we've recently also had a webinar on diabetic retinopathy. But one thing that I must tell is that we're doing a lot of AI screening where we don't include the peripheral retina. And in Indians, we do tend to have something called as predominantly peripheral lesions in diabetic retinopathy, and that tends to get missed. So our grading itself may not be very accurate. Hence, dilatation or with wide field imaging fundus camera, the peripheral retinal screening becomes extremely important. What I will be speaking on today is predominantly the peripheral retinal degenerations, because those are the ones that can predispose to several diseases, can predispose to several morbidity, especially in those patients who are undergoing cataract and refractive surgery. I'll also touch upon when to treat them and the recommendations for patients who are undergoing surgery. So quickly going to the different peripheral retinal degenerations, we need to understand the terminologies first. We know what degeneration is. And when it occurs in the retina, it's called as loss of structure or function of the cells in the retinal tissue itself. And finally, you have peripheral retinal degeneration and macular degeneration. Well, today we'll focus primarily on the peripheral degeneration. So based on the location of the lesion, you can have either vitreoretinal, intraretinal, or chorioretinal. And I've highlighted some of the important lesions here in red. Now, why exactly are these lesions important is because they are located anterior to the equator and they can be easily missed. They can be associated with atrophic retinal breaks or can develop even a dynamic retinal tear and hence can predispose to a rhegmatogenous RD. So let's look at some of the common and important degenerations. First is the snail track degeneration. It's important because it's of the same size, the shape, the orientation, the location as lattices occur. It can also be associated with the retinal hole, as you can see in this image. The OCT generally shows an irregular retinal surface and hyper-reflective dots, which are primarily lipid deposits. Now, this is how you can see the irregular retinal surface, and very clearly you can see an atrophic retinal hole there with a cuff of SRF as well. We are able to take these images even with our regular OCT devices that we have, but given the new OCTs that can take extreme periphery, it becomes a very invaluable tool for an additional screening system for peripheral retinal degenerations. These are some of the vitreous changes that we can see in snail track degeneration. Now, coming to lattice degeneration, there is retinal thinning with loss of neurosensory layer. The vitreoretinal adhesion at the margin of the lesion can also be seen. This is one of the most common peripheral retinal degenerations that we see, and it can be seen even with those without any predisposing lesion conditions. Seen in general population, 6 to 8% of patients, we see retinal lesions such as lattice degeneration. They're usually cigar shaped. Here you can see some more lesions. They're circumferentially oriented and located at or anterior to the equator. There's a well-outlined thinning with white crisscrossing lines. Their atypical lesions also are noted adjacent to vessels. They can be seen radially, like in Stickler syndrome. You can have one lesion, multiple lesions, 360-degree lesions. Yellow deposits are seen, pigments, atrophic holes or retinal tears can also be seen, as you can see in all these different images. So these are some of the OCT findings. You can see the vitreoretinal, adhesion at the edge of the lattice degeneration in these OCT scans. Now coming to retinal holes, again, very, very important lesions. They're either isolated or they can be seen either with snail track or lattice degeneration, as I showed you in a couple of images before. Atrophic retinal holes, basically there's no posterior cortical vitreous separation there, whereas with an operculated retinal hole, it indicates that the cortical vitreous overlying the retinal hole has actually separated. You see retinal holes with a cuff of SRF. This indicates that there is significant traction at the margin of the retinal hole, and these can surely lead to retinal detachment. Now coming to retinal tears or horseshoe tears, these are dynamic tears. You can see here a typical horseshoe shaped tear and the flap of the retina as well. These definitely would require immediate attention because they're dynamic and can extend to lead to a retinal detachment. These are some innocuous lesions such as the snowflake degeneration. This is basically a fibrillar anomaly of the vitreous. The peripheral retinal abnormalities include just minute crystalline deposits that resemble snowflakes, and they're also associated with the early onset cataract. Generally, no tractional changes by the vitreous is noted in these lesions. Paving stone degeneration also extremely common. This is seen in 25% of the population. There's chorioretinal degeneration. There are well-defined yellow-white patches between the equator and the ora serrata. And there's absence of outer layers in the retina, in the photoreceptor and the ELM, which basically permits an uninterrupted view of the choroidal vessels in these lesions, where you can see in this image very clearly. Again, no predisposition to break formation with these lesions. White without pressure, commonly noted, the peripheral retina appears opaque without any depression. It's generally seen in the elderly and in myopes. The borders are ill-defined and they're located adjacent to the ora serrata. Giant retinal tears and retinal detachment can occur at the border of these white without pressure. Dark without pressure, Again, here you can see these patches, which are also associated with white without pressure. So you can see here more clearly delineated dark without pressure. What are the differences here is white without pressure is peripheral, whereas dark without pressure is seen mid-periphery. There is hyperreflectivity of outer retinal layers. Here you see hyporeflectivity. White without pressure is ill-defined, whereas dark without pressure is better defined and well demarcated. So we've seen all these peripheral lesions. What causes RD in this eye with a peripheral retinal degeneration? Well, the most important here is the posterior vitreous detachment. Once the posterior vitreous detachment occurs, this lesions open up and can lead to a retinal detachment. So what are the symptoms of acute symptomatic PVD? It's like I said, they come with flashes and floaters. It can cause vitreous hemorrhage, retinal tears, retinal detachment. We need to be extremely careful about examining these patients because the vitreous hemorrhage might mask the lesions that we need to examine. Hence, we need to repeat the examination after 4 to 6 weeks, as the process of PVD may also still be progressing, and PVD with hemorrhage and pigments are more likely to develop retinal tears or already have coexisting retinal tears. Hence, a careful examination is mandatory. So when do you treat these patients? So this is a question I usually ask the audience. This is a 26-year-old female who comes for a routine checkup and someone who wants to undergo surgery. Would there be a difference? Well, there is a mixed opinion. Every time I've asked the audience, some of them say, yes, I will treat them. Some of them say, if she's undergoing surgery, I will treat. If or without surgery, I will treat. And some will say, I'll just follow up this patient because this is just a lattice degeneration with no hole, with no traction. And we do want to observe these patients most often. Now, that brings us to the point that we don't have uniform guidelines to treat our patients. No clear recommendation as such. Most of them have doubts and confusion about certain lesions. But important is that these are patients undergoing cataract or refractive surgery whom we are promising 6/6 vision. So medical legal issues can definitely be forefront. Most of the existing guidelines are by the academy based on Western data, and they do not take into account difficult clinical situation. So a suggested approach is what is the lesion? What are the vitreous changes around the lesion? And what are the risk factors in that particular patient for developing a retinal detachment? So some of the recommendations is, should we treat all lesions? Let us show you some data from our institute. We've looked at patients between November 2020 to 21. Eyes undergoing refractive surgery with more than 3,000 patients. In these, only 285 patients had lattice degeneration, of which laser was done only in 94, and most of them did not receive laser barrage therapy. And if you'll notice there, none of these patients had retinal detachment. In fact, a patient who did not have a lattice degeneration developed a retinal detachment. So are we, is it an overkill barraging all patients? Well, we need to take a closer look and to the recommendations that are published. All symptomatic and asymptomatic horseshoe tears, operculated holes, lattice degenerations with retinal holes, and atrophic holes should be treated promptly, irrespective of whether the patient is undergoing a procedure or not, because these have a higher predisposition to developing retinal detachment. All the others can usually be followed up closely, but if any symptomatic lesion is there with or without a retinal hole or atrophic hole also, treatment is recommended. So what about timing for surgery? The patients are, in a major hurry to undergo the surgery. When do you do surgery for these patients? Well, again, a dilated retinal examination is preferably to be done. And after the laser treatment is done, preferably for 7 to 14 days, you can wait before the patient undergoes any sort of invasive procedure. And preferably again, post-surgery, 2 weeks later, retinal dilated examination again is advisable. Now, who should do the screening? Dilated retinal examination is part of any comprehensive eye examination, and any ophthalmologist should be able to do a good peripheral retinal evaluation. Most myopes actually have a posterior migrated ora serrata, which actually makes it very easy for us to pick up lesions. If you're not confident about indirect ophthalmology, then you can refer to a retina specialist, or you can adopt wide field fundus imaging. So all patients undergoing cataract and refractive surgery should undergo a clinical dilated retinal examination for these lesions. Prophylactic barrage laser photocoagulation for those predisposing lesions at least a week or 2 before surgery. And retinal examination should be done at regular intervals because these patients are high myopes. They still can develop PVD, retinal tears, retinal detachment, and other macular pathologies. So they do need a frequent examination. Just because they've undergone refractive surgery, we cannot excuse them from a regular follow-up. Thank you so much.
Thank you, Dr. Chaitra, for highlighting those guidelines and clearing up the confusion about where, when, and how to treat these peripheral lesions. So with that, I move on to the chairpersons for their perspectives. Dr. Babu, would you like to add something to this, or do you have any practical tip to share?
Muted.
Sir, you're muted.
Yeah. So one thing I want to highlight is a good peripheral examination by a ophthalmologist, which is not gone so well in our country. So general ophthalmologists, whoever listening to this, should practice a good indirect ophthalmoscopy, and they should be able to pick up the lesions. Okay, that is number one. Number two is round holes without any cuff of fluid. Usually I differ in laser unless you are going for any laser, LASIK or cataract surgery, because these are innocent lesions and usually do not lead to any rhegmatogenous retinal detachment. However, a peripheral traction, since you have the OCT, you can perform the OCT even in the periphery and see whether there is any vitreous traction. If traction is there, then you should not take it easy. These are the two lesions. Other snowflake degeneration and paving stone degenerations, we should identify and explain to the patient that they are innocent lesions. Those lesions do not require any treatment. White without pressure is innocent, but if the fellow is having a history of giant retinal tear or a retinal detachment, it may amount for prophylactic barrage laser.
Yeah, just a point here. Definitely before doing a refractive surgery, it is important to do a retinal exam, but also not to do an prophylactic kind of 360 degrees barrage laser when there are no lesions. That can itself trigger an RD, tears and retinal detachment, by causing vitreous contraction. In fact, in any case where there are very extensive lesions, by doing a barrage laser, we do also increase the risk of a detachment by triggering vitreous contraction. So the patient should be informed of that risk as well. While we are closing lesions, we are also increasing the risk of detachment. So it's a fine.
I think I want to highlight that if you are doing a barrage laser, it is not only protective. Certain times the vitreous around the barrage laser again can be a cause for traction, and that can cause a retinal break and then lead to a retinal detachment.
Yes, true.
So Dr. Chaitra, after a cataract surgery, patient comes in with, symptoms of floaters. So do you think every patient who comes in with floaters after cataract surgery should be dilated and checked? Or it's just flashes that...
Ideally, yes, definitely those patients who had a complicated cataract surgery, for sure, because we know that PVD induction occurs quite commonly after cataract surgery. But if they've had pre-existing floaters, some of them tend to just start seeing them clearly, after the cataract surgery. Still, it would be advisable to see them because we just can assess the situation post-operatively, and it gives us a good idea of when to call them for a follow-up. Because without knowing for sure what's going on, that would be ideal. And one other point that I saw while I was reading, Tinku, is that most of the new lesions that occur tend to be in the same quadrant as the pre-existing ones. So that was something else that I saw in literature. So maybe we need to also take a closer look at that particular quadrant to see if any new lesions have developed in a patient who is symptomatic.
Hey, Tinku, in 40 minutes, we have finished only 2 talks. I think we have to be...
We'll move on to the next talk. So thank you for your inputs. So our next speaker is Dr. Neha Goyal. She'll be speaking to us and sharing her clinical pearls on central serous retinopathy. So Dr. Neha is an assistant professor of ophthalmology at the Army College of Medical Services, New Delhi, a senior consultant, Vitreoretina and Uvea at the Synergy Eye Care Center, at New Delhi, and she's also the director of the Tetraview Super Specialty Eye Center, New Delhi. So Dr. Neha has been speaking on central cedar retinopathy and I mean, she has some great clinical data. So looking forward to your pearls, Dr. Neha.
Thank you so much, Dr. Tinku. Thank you, AIS, ARC, Dr. Prashant, Dr. Tinku, for including me in this section, which appears to be very useful. My regards to the chairpersons and to all the other speakers. Are my slides visible?
Yes.
Yeah.
Yeah, very.
So I'll be talking about central serous chorioretinopathy, and this is a brief overview of my talk. We all know the typical demographic profile and have some idea about the etiology of CSC right from our post-graduation days. CSC is almost synonymous with OCT, the indications of treatment and the options available. What I hope to shed light on is on the current concepts on the pathophysiology, which has changed over the last few years, and I feel everyone should know about it. As I said, OCT is indispensable, but we look at what other things we can see on OCT and multimodal imaging, how it contributes, and then the clinical pearls, the CSC mimickers, which is the major part of the talk, an update on the management as well. So we now classify CSC as part of the pachychoroid disease spectrum. What does this mean? It's not just a thickening of the choroid, which can be focal or diffuse, but also loss of the small medium vessels and dilatation of the large choroidal vessels known as the pachyvessels. So these are terms which have come up with the introduction of EDI and swept source OCT. And if you compare this with the normal eye, you can see the stark contrast between a thickened choroid and a normal choroid. These pachyvessels, they, if you look at them on fast OCT or ICG, they don't taper towards the posterior pole, but they retain their large caliber and they terminate abruptly. So it is this choroidal congestion and hyperpermeability which is the culprit, and this results in focal RPE defects, which can come to us clinically as a serous PED and or a neurosensory detachment, which we recognize as central serous chorioretinopathy. So this is a serous PED and this is a neurosensory detachment. So we know that it's more common in males, but this gender predilection decreases with age, and also the bilaterality increases with age. So the first picture is of a PED. Clinically, you see it's more well-defined, more reddish as is classically described. The side picture is of a neurosensory detachment. It is more diffuse and you can see the color is more transparent compared to a PED. Now, looking at acute CSC, this is a case of acute CSC. On the autofluorescence, you see mild hyperautofluorescence, and we usually end up doing angiography for the cases which do persist. And here you can see the classic ink blot leak pattern. So here you see there are two bullae and both have their own point of leakage. And I've investigated or worked on a lot of the OCT findings at the site of the leak. And we now know that here there's usually a blowout or a focal RP defect. So this is the typical smokestack leak, the classification we've been classically following. And here again, you see the PED and the sagging sign. So this is how I've summarized the point of leak as you see on OCT, because you may angiography may be contraindicated in certain patients. You can have a protruding RPE, a PED, a sagging or dipping of the neurosensory retina at that point. And then the picture which Dr. Mudit was talking about, the subretinal fibrin, which is also called a vacuole sign with a central clearing, and it's more commonly seen in patients with steroid-induced CSC. So OCT not just tells us the diagnosis, the monitoring, the leakage point, but it is also important in identifying whether the disease has been acute or chronic and prognosticating thereafter. So here you can see this is an acute CSC. Now, if you compare with this, here you see the shaggy photoreceptors or the elongated photoreceptor outer segments, which suggest chronicity, as do these hyperreflective dots in the subretinal fluid or cystoid changes, whereas otherwise it appears like acute CSC. You don't see the RP changes or the photoreceptor loss, but these are the signs which give the subtle hints that you are dealing with the chronic CSC. So next, I want to talk about autofluorescence in CSC because it is a bit underutilized. It is helpful in determining chronicity again. Acute CSC is usually hyper FAF, whereas in chronic, you can see these small discrete dots, and they correspond to the subretinal precipitates, which I showed earlier. So in fact, the current let's talk about the sequelae first. So we know that these RP tracts, as seen clinically, and they are more accentuated on autofluorescence. They can be both hyper AF or hypo AF. And these hyper AF tracts are said to be formed relatively recently. So this can again help us in prognosticating the patient. These, whereas you see, these are hypo AF. That's because hyper AF means that is the debris which is there, the photoreceptor debris, etc., which is there, whereas hypo AF means there is actual loss of the RP over there. The current CSC International Study Group has in fact classified CSC into simple and complex because the division into acute and chronic has been a bit arbitrary. And this is dependent on one of the major criteria is the area of RP atrophy as seen clinically or on FAF. So if this is less than 2 disc areas, it's called simple. If it's more, it's complex. And this is naturally more severe disease, recurrent, and needs early intervention. Another term I want to introduce here is the pachychoroid pigment epitheliopathy. Many times we used to call this healed CSC, but now we know that there are areas of these pachy vessels which overlie with overlying RP changes, and these patients have never had SRF, which has been documented. Commonly, we see them in fellow eyes of patients with CSC. So now coming to the CSC mimickers, and this I'll be discussing with the help of certain cases. This was a elderly male who complained of suboptimal visual gain after cataract surgery. He was 6/12. We can see this neurosensory detachment with some elongated photoreceptor outer segments, ill-defined leakage on angiography. But look at the octa here. We see a neovascular lesion. And if you go back and look at the OCT carefully, then there is the presence of a double layer sign, which suggests that this is pachychoroid neovasculopathy, which we are dealing with. This is basically a type 1 neovascularization, not a part of the AMD spectrum. And of course, the clinical significance is that this patient would need an anti-VEGF injection and not observation or lasers. Another case, this again, the OCT looks very much like a neurosensory detachment and may be labeled erroneously as a CSC. But if you look at the fundus, you see the disc is hyperemic, there's a yellowish tinge, and it leaks on fluorescent angiography. You also see these hypofluorescent lesions, which later on stain. So, and if you go back and look at the OCT again, then you see the line of the choroid is not straight. There is choroidal elevation and thickening, and these are septate NSD, which are now described as the bacillary layer detachment, which may be seen in the VKH syndrome. So this again important to recognize, because if you misdiagnose it as CSC, then you would just observe it, whereas this patient needs steroid therapy, and here it is with complete resolution. Another case, this was a young female who came with decreased vision and left-sided headache. Again, she was referred to me as a case of CSC. Vision was 6/12. FFA didn't show any leak, just a hot disc and some ill-defined hyperfluorescence. The clue here was in the headache. And again, if you look at the choroid, it is undulating. So this was actually a case of posterior scleritis. And it is important because it may be the first manifestation of a systemic disease such as Wegener's or polyarthritis nodosa. And again, these patients need steroids or immunosuppressants. So not CSC, this is also a inflammatory disorder. Now look at this patient. This patient was actually a myope elderly female, and there are some RP alterations clinically on FAF and this neurosensory detachment, which looks very much like a chronic CSC. But no pachy vessels on ICG. Now here I want to show you, this was the vertical scan that we were looking at and diagnosed it as CSC. But look at the horizontal scan. This is actually a case of dome-shaped macula with a SRF. Now, dome-shaped maculopathy is another recent term which has been described. Inward deviation of the macula seen mostly in high myopes, but also in emmetropes. Now, the dome can be horizontal, vertical, or round. If it's horizontal, you need a vertical scan to diagnose it, and this is the most common variety. For a vertical dome, you need a horizontal scan, and a circular dome can be seen in both. Now, importantly, if you do a horizontal scan in this, you will miss the dome. Similarly, a vertical scan will miss this. And a scan of inadequate length will miss both on horizontal and vertical scans. It's important to recognize DSM because unlike CSC, this will not respond to medical management or any laser or PDT, and the natural history is of spontaneous resolution itself. Now, another case, again, you see a neurosensory detachment, you're tempted to label them as CSC. But apart from a clinical examination, even if you look at the OCT films yourself and not just a printout, you see this lesion here present superiorly. And this was actually a case of choroidal hemangioma with neurosensory detachment. OCT through the lesion also shows the elevation, and this is following PDT. Now, this is the sixth clinical pearl, so as to say a middle-aged female with a decreased vision in the right eye and a neurosensory detachment. So again, here, clinical examination, the importance cannot be overemphasized. Look at the disc. Look carefully. This was actually a case of optic disc pit-related maculopathy. And they commonly present with SRF. They may have subretinal deposits identical to CSC. This was a rare case with 2 optic discs and a neurosensory detachment. So we know the typical optic disc pit maculopathy has the outer retinal hole and the schisis, but then there are also cases which present only with SRF, and these can add to the etiopathogenesis. Now, this is a question that was actually asked in my Viva almost 15 years back. What will you do next when you see this OCT picture? And Professor S.P. Garg happened to teach me a lesson for life by this question. So most of the students or ophthalmologists would be tempted to say it's CHC, there's a neurosensory detachment, and I would like to do an angiography to find the leak. But look carefully, whenever you see a neurosensory detachment where you cannot see the limit on your OCT, then go back. And the answer to sir's question was, I will do a distant direct ophthalmoscopy because this patient had a very shallow RD, and that would give you the gray reflex. So this is another case. So, and if you look at the OCT picture, again, you see these retinal folds, the inner retinal corrugations and intraretinal edema, which you will not see in CSC. And believe me, we've seen a lot of cases of shallow retinal detachment being referred as CSC. Here is the inferior RD, as you can see. So this is the last case, and here again you see a space between the neurosensory retina and the RP. You again might label it as CSE, but going back to the clinical picture, this is a pseudohypopion, which is hyperautofluorescent, and here we are dealing with actually the best vitelliform macular dystrophy. So just to summarize, there are a host of lesions which present with NSD and may look like CSC, but they may be neovascularization, inflammation, they may even be tumors or detachment or rare disorders like DSM, optic disc pit. And in all these cases, the management is different. For neovascularization, we'll go towards anti-VEGF. Inflammation needs steroids and systemic evaluation. Tumors have their own treatment. RD will, of course, require surgery, and the prognosis differs in the other cases. Just one word about the management I would like to say, especially for the all the general ophthalmologists, that apart from the risk factor modification, which we all know about, it's classically been taught that acute CSC, most cases resolve, more than 90% cases resolve within 3 to 4 months. So a first episode requires a conservative approach. Treatment is usually only ventured for in cases which demand, quick visual recovery, bilateral cases, one-eye patients, or other eye loss to CSC. However, recent literature has shown that there may be better functional outcomes with prompt intervention, even with acute CSC. So we are not just talking about the recovery on OCT or the visual recovery, but we've ourselves looked at contrast sensitivity and multifocal ERG in patients with acute CSC treated immediately or conventionally after 3 months. And we've seen better contrast and better waveforms on multifocal ERG at the end of the follow-up, which was around 6 months. So laser and PDT of course is not available, but laser is the option for extrafoveal leaks, which can be subthreshold or micropulse. In medical therapy, eplerenone is being used very widely, even by a lot of general ophthalmologists. I'd just like to caution that always keep the physician in the loop, because this does lower the BP and alter the serum potassium levels. Please do inquire if the patient is already on antihypertensives. Miscellaneous, there are a host of agents which actually have not shown, in RCTs any considerable benefit. So CSC is actually the fourth most common non-surgical retinopathy associated with fluid leakage. The pathogenesis is still not completely understood, but it is now classified as part of the pachychoroid disease spectrum. Not all neurosensory detachments on OCT are CSC. Clinical history, multimodal imaging can help to clinch the correct diagnosis and avert severe permanent visual loss in many cases. So multimodal imaging can be also utilized to detect predictive biomarkers with regards to the duration and the prognosis. And while spontaneous resolution has good visual outcomes, early intervention can give you good functional outcomes as well. Thank you.
Thank you, Dr. Neha, for that wonderfully illustrated talk. And you highlighted the mimickers also extremely well. Just a quick question. When you say early treatment, what do you mean by, is it at presentation or do you still wait?
Yes, at presentation. So even as early as 7 days of presentation. So of course, many times it's always discussed with the patient, even in the informed consent is taken that you do have an option of spontaneous resolution. But the ones who choose or are randomized to treatment, they do show a better functional recovery.
Thank you. So some quick comments by the
Yeah,
chairperson.
we need to be very, very quick actually. CSR the management, not only laser, okay, pachychoroid component should be identified, and if pachychoroid component is there, then probably laser is dangerous also. We have seen neovascularization develop because certain times in clinical examination, double layer sign we will miss, and unfortunately it will create a neovascularization formation. And dome-shaped maculopathy, always observe unless there is a doubt of neovascularization, you should not treat. These are the 2 points I want to tell. Rest she covered.
There's many times these chronic CSRs may resemble AMD, and especially if they're exudative types.
Yes.
So one very important point is gravitational track of exudation or RP atrophy going down towards the 6 o'clock position clinches the diagnosis for CSR because the treatment is different. And Octa has a very important role in identifying CNVM in CSCR. So when you are doing OCT in any case of CSR, always also do an Octa so that we can address with anti-VEGF if there is a CNVM.
Thank you.
Thanks. We can
So
move
with
on.
that, yeah, we move on to our next speaker, and that is Dr. Mayank Bansal. Dr. Mayank is the director of the Claritas Eye and Retina Center in New Delhi. So Dr. Mayank is not only an astute vitreoretina specialist, but he's also doing great work in ophthalmic genetics. So today he'll be sharing his clinical pearls in age-related macular degeneration. Over to you, Dr. Mayank.
Well, thank you so much for the invitation and this opportunity to present. So I'll be moving quickly in the interest of time, and I'll be mainly covering on these points on dry AMD and these on neovascular AMD. So dry AMD, one of the main risk factors is oxidative stress, and cigarette smoking is known to be one of the main risk factors for it. This oxidative damage leads to formation of drusen's, which triggers complement cascade, and then therefore cell death, which eventually leads to geographic atrophy. When we look at patients, one of the most indispensable investigation is the OCT, and we're essentially looking at patients showing certain particular OCT biomarkers. One of the important things that would be wise to differentiate is soft versus the hard drusen's, wherein soft drusen's, which have very less fuzzy margins, they're not as discrete, and they're larger in size, tend to have a higher risk of vision loss and would warrant a more closer follow-up as against a hard drusen. There are certain other OCT biomarkers which are wise to look at. So a higher central drusen volume, hyporeflective drusen core, and intraretinal hyperreflective foci, as well as subretinal drusenoid deposits. All of these would be poor prognostic markers whenever we're looking at patients with dry AMD. Autofluorescence, which essentially shows the lipofuscin activity, is also very useful. And initially, while there is increase in hyperautofluorescence, there is eventually, with the cell death, cell loss, we start to see hypoautofluorescence. In the study, they've also compared the microperimetry, which is showing lesser values with the progression of the dry AMD. Geographic atrophy, which eventually a person with dry AMD may progress towards, shows increase in hypoautofluorescence and an increase in choroidal hypertransmission as the RP layer, which is hyperreflective, starts to die down. Management is essentially helpful to make patient the part of the treatment plan, encourage them to stop smoking if they already are, and encourage self-monitoring using Amsler grid. The mainstay of treatment at the moment is AREDS2. There has been beta carotene, which has been taken off now largely because of increased risk of lung cancer associated with it, as well as reduction in the zinc dose because it can lead to more genitourinary complications. Further, when we do follow up patients, it's important to stratify them. So those who have a more high-risk OCT features, which we spoke about, like intraretinal hyperreflective foci, should be called in more early on, image them every 3 months, as well as patients who have a more geographic atrophy. And those who have a lower risk OCT, such as small, hard drusen, can be reevaluated every 6 months or so. More recent advances in treatment include C3 inhibition as well as C5 inhibition, as well as regenerative cell-based therapy. So wherein patient-derived iPSCs, which are differentiated into RP, can be injected into the subretinal space and may cause regeneration. This, of course, is not FDA approved at the moment, but studies, including one from India as well, is in phase 1-2. So while this is about dry AMD, sometimes patients who are presenting mostly with drusens may also have an underlying CNVM, or choroidal neovascular membrane. And therefore, again, the importance of OCT for each patient who has such clinical findings. So intraretinal fluid, of course, there are many findings, but intraretinal fluid is a very poor prognostic factor for patients with neovascular AMD, not going into the classification as type 1, which is sub-RP, then type 2, which is subretinal, and intraretinal, which is type 3. FA and ICG definitely have a role, but there is more and more growing role of OCT angiography when it comes to documenting patients with or diagnosing patients with choroidal neovascularization. So essentially, one of the most initially when OCTA was launched, we saw two important patterns of choroidal neovascularization. One was something known as what we saw as a CFAN pattern of choroidal neovascularization with a very strong prominent feeder vessel, and along with that, this choroidal neovascular complex, which has got a CFAN-like appearance. And the other pattern we noticed was something known as a Medusa head pattern, in which there's a central prominent vessel, feeder vessel, and then along with that, in all directions, the choroidal neovascular membrane. One important thing that we noticed was that when you treat patients with anti-VEGFs, although there is a reduction in the size of the finer vessels, the feeder vessel does tend to persist, which also explains why these fluids or membranes tend to recur despite anti-VEGF therapy. More such examples of CNVM as seen on OCT angio. But I'll come to therapy now, wherein anti-VEGFs have seen a evolution over a period of time. And the goal has been to increase the period of the injection-free interval, with more recent drugs having more of a dual pathway inhibition, such as faricimab, where we're seeing both VEGF as well as Ang2 pathway inhibition. But if I was to summarize all the treatment options that we have, if case there is any patient who has a history of intraocular inflammation, it's best to avoid brolucizumab given the previous reports of occlusive retinal events, as well as if there's any patient who is not responding to any initial agent, it's wise to consider another molecule which may overcome the tachyphylaxis we see and consider dual pathway inhibition, such as with faricimab. Otherwise, the treatment interval now with aflibercept, brolucizumab, faricimab can be now extended to 8 to 16-week interval. Sometimes, unfortunately, we might come across a submacular bleed, typically seen in patients who never seek treatment or who have trailed off treatment or who are on anticoagulant treatment or who are perhaps hypertensive. treatment plan in such cases would be dependent on the size of bleeding. With smaller subretinal bleeds, I'm able to anti-VEGF intravitreally or TPA given intravitreally with or without pneumatic displacement. But for larger bleeds, often we might need to give subretinal TPA with anti-VEGF. Timing is critical because in case there is a patient who has had a long-standing bleed, therein we are not able to achieve much goal without much resolution despite doing a treatment with subretinal TPA. So very quickly, a surgical video wherein there was a patient who presented with with a vitreous hemorrhage, and the OCT and history was suggestive. The ultrasound and history was suggestive of perhaps subretinal bleed. So we went ahead with giving the patient tissue plasminogen activator with subretinal aflibercept. And the key here while operating, of course, is to go very slow with the subretinal injection so as to prevent a macular blowout. Dosage remains around 50 microns given in uh, 0.1 to 0.4 ml, and then doing a fluid agar exchange and allowing the patient to be either in a propped up position. So although the vision changed from hand motions to 3/60, but definitely there was, given the older nature of the bleed, there was still a the patient was definitely still happy with the improvement in vision. Another patient who had a hand motion vision loss, we treated with giving subretinal TPA along with aflibercept, and there was a central scarring and two actual mounds, one inferior and one superior one. So therefore, two separate sites given at an area where there's slight lifting of the retina so as to not really cause a damage to the choroidal. So one of the questions that get asked at this moment is that is there a need for lasering these retinotomies? So often there's no need to laser these 38 gauge retinotomies. And after this, again, the patient's requested to maintain a propped up position. And we see a vision change in this particular patient from hand motions to 3/60. And another smaller bleed that we saw for another patient, wherein the vision was 3/60 to begin with, and improved to eventually very similar surgery. So I'll skip through all of it. But yeah, coming to other recent advances, there is the RGX-314 as a gene therapy that can be used. Of course, not in India yet, but in this therapy, there is DNA which is coding for the Fab antibody against the VEGF, which is packaged into the AAV, similar to ranibizumab. The goal here again is to reduce the need for repeated injections. It's given as a subretinal injection. So to conclude everything, take-home pearls encourage smoking cessation in patients, self-monitoring through Amsler Grid. While multimodal imaging is useful, OCT remains indispensable for diagnosis of all of these patients and further follow-up follow-up visits of the patient. And dry AMD, the treatment mainstay remains AREDS2 formulation, while there is increasing role that we're seeing of complement inhibition as well as cell-based therapy. Wet AMD, there is newer anti-VEGFs which help increase the injection-free period, with now more and more evidence towards role of subretinal TPA for submacular bleeding. Thank you.
Thank you, Dr. Mayank, for so crisply summarizing all the key points of this very complex condition. We have a few questions that which people want to know, that how do you prescribe the antioxidants? What do you tell the patient? You give them monthly or 3 monthly, or what is your protocol? And when you see a patient of dry AMD, what are the other things that you ask the patient to do, and how do you
So
prescribe?
given that there aren't many risks associated with the AREDS2 formulation, I advise them to continue it long term, especially who are very high risk. Definitely continue it very long term. The geographic atrophy patients, one eye has got an exudative neovascular AMD, the other's got soft drusen's or geographic atrophy, very high risk. So they should definitely continue.
It is meant to be taken lifetime. There is no, and in fact, it's not meant to give breaks also. In fact, it's meant to be given twice a day, but we give once a day. So we are not overdosing the patient at all.
Yeah,
So,
once a day, or certain times after giving for a year or two, you can make it alternate.
yes.
Should not
So
be
I
a
think
big this thing,
a
but they
lot of
should take continuously. Second, monitoring the Amsler is very essential, and they should quit smoking very strictly. and good dietary habits.
Tobacco chewing also, any type of tobacco.
Yeah,
use.
yeah, that I agree. Some
about-
people they say they don't smoke but chew tobacco.
Also
Sun
UV
gazing
ray exposure.
as a part of ritual. Sun gazing.
Yes.
Yeah.
Yes.
And another high risk factor in Mayank, in your this thing, you have said large drusen RP pigmentation is also considered as one of the risk factors in dry AMD for development of CNVM. So that need to be observed for.
True. So thank you so much. Thank you, Dr. Mayank. And with that, I now invite Dr. Malika Goyal to present her talk on vein occlusions. So
Thank you so much, Dr. Tinku, for this honor and opportunity. And thanks to ARC and Dr. Prashant and Dr. Ajit Babu. I'll be speaking on retinal vein occlusions. So when we see a patient with this, the most important thing is to look for what is the cause, which is usually hypertension, diabetes, dyslipidemias, or tobacco use. Patient may not often be aware that they are hypertensive, so check the blood pressure in the OPD. In younger patients, it is more often inflammation, which can be idiopathic, homocystinemia, antiphospholipid syndrome, or medications like oral contraceptive pills or sildenafil called Viagra. Now, when we identify RVO, we should look carefully for glaucoma. This is the commonest comorbidity as well as a risk factor for RVO. Look at the disc in both eyes. And if it is suspected or diagnosed as glaucoma, avoid intravitreal steroid injections, which can cause worsening of glaucoma. And the glaucoma surgeon should avoid using prostaglandin analogs or alpha agonists, which can worsen the macular edema caused by RVO. RVO is classified based on its occlusion site as central retinal vein occlusion, hemiretinal, or branch retinal vein occlusion. The first two may be ischemic or non-ischemic. The non-ischemic type of CRVO, HRVO present with macular edema, which is milder, good vision, and recover reasonably good vision with fewer injections. On the other hand, ischemic type presents with drastic vision loss, extensive hemorrhage, very severe macular edema, and the visual prognosis remains guarded. Even when the edema resolves, the vision doesn't improve because of ischemia. Often the vision is disproportionately poor compared to the degree of edema. As you see here, the macular ischemia, even after the macular edema has resolved, and these cases require vigilance for neovascularization on the iris and NVG. Sometimes an RVO, which looks non-ischemic, may present with very poor vision, and that could be due to associated cilioretinal artery occlusion, which can nowadays be easily identified by doing an OCT angio in that area, and you see the hypoperfusion related to the cilioretinal artery occlusion. Hemiretinal would be superior or inferior half, and again, because of its extent, large extent, it can cause NVI and NVG. Earlier, this used to happen at the roughly the 3-month mark from diagnosis. But nowadays, we see it after we stop giving anti-VEGF injections for the macular edema. That is when they start having the risk for developing neovascular glaucoma. So after we stop injections is the time to counsel them to report any pain, redness, photophobia, etc. And even non-ischemic CRVO, HRVO are not safe. They often progress to ischemic type over time. So they also have to be kept under observation. Branch retinal vein occlusion could be in any one of the 4 quadrants. The nasal BRVO remains asymptomatic till it develops proliferative retinopathy and serious complications. The macular complications of branch retinal vein occlusion include cystoid macular edema, which responds to injections, macular hemorrhage, epiretinal membrane in chronic untreated CS cystoid macular edema, and even macular hole from chronic macular edema. And this is a patient who was being treated regularly with anti-VEGFs. But despite that, went on to develop a macular hole with sudden drop in vision. And again, epimacular membrane and macular hole in a patient with BRVO. Interestingly, also, hard exudates can develop very rapidly, especially those with uncontrolled diabetes and dyslipidemias. And once they involve the fovea, the vision may never be the same, even if treatment helps to resolve these exudates. They need more intensive intravitreal injections than just fluid. which means higher number of injections with a greater frequency. And it is more important to prevent the foveal center involvement with injections before the center gets involved, rather than chasing them later. However, injections do help, as you see in this patient. Within a span of 9 months and 3 injections, the exudates have resolved with good vision. Another patient of BRVO who did not come back for a year and then came with massive hard exudates, treated with 3 injections, and in 10 months you can see the resolution. But that may not always be the case. Edema is not the only problem. Macular ischemia is a problem. There is no edema here, as you see, but the vision is very poor. Ischemia is seen as hyperreflectivity. BRVO also needs careful annual examination for new vessels, which may be asymptomatic. Both these patients are asymptomatic. As you see, NVD, these are asymptomatic patients and they require scatter laser to prevent complete vision loss from vitreous hemorrhage, fractional retinal detachment, etc. Again, asymptomatic patients on annual review, treated with scatter laser. So also look at the other eye every time. And these are usually asymptomatic, so need very careful exam. Again, an inferotemporal BRVO with NVD, which has regressed on treatment. And often they may require scatter laser extending into the adjacent quadrants, almost like a pan-retinal photocoagulation, because just treating in the affected quadrant is often not enough. The new vessels do not regress. And they may come like this with vitreous hemorrhage, macular ischemia, and they need an extensive scatter laser on the operation table itself. Macular branch vein occlusions do not cause proliferative retinopathy because the extent of involvement is small, but they do have recurrent edema and persistent macular edema as well. Now, imaging, we will go along. As we see, not only macular edema, but the hyperreflectivity shows ischemia on the OCT. And fundus photographs are also very important because, as you see, the OCT has not changed in 4 years, but hard exudates have resolved, and that can only be captured on the fundus photography. So we are at least reassured that treatment is working in some way, if not in another way. So for photography is very important for hard exudates, new vessels, hemorrhages. And OCT angiogram, very important. Sometimes it shows new vessels on the disc or elsewhere, which we were not expecting. It helps to make the diagnosis where the fundus starts looking normal in a case of BRVO, macular BRVO, or even otherwise. You can see the hypoperfusion makes the diagnosis. Sometimes, however, we need a fluorescent angiography. The motion artifacts do not allow OCT angio. And here there was no diagnosis on the photograph, but fluorescent angio shows that this is a BRVO and not a macroaneurysm, and allows us to do the laser in that area so that the hard exudates may resolve. The hard exudates are diametrically opposed to the area where laser is required, as you see here. Similarly here, fluorescent gives the leakage, which Octa cannot give. Leakage cannot be identified. So laser for macular edema requires fluorescent angiography, though FFA can pick up new vessels in opaque media, which OCT angiography cannot, and can also pick up new vessels on the iris, as you see on the right side. Treatment for all retinal vein occlusions, the first treatment is serial anti-VEGF injections, and then secondary role is laser, intravitreal steroids, or vitrectomy. These are the intravitreal injection options, roughly the same as discussed earlier for AMD, and steroids. Steroids are used sparingly and as a second line because they cause these complications. Migration into the anterior chamber can happen if there is a large PC opening. So when do we use steroids? Only when anti-VEGF response is not good or when anti-VEGF are contraindicated. Laser for BRVO still has a role where we find that we require repeated injections. There is recurrent macular edema. So after a few months, we can consider macular laser. It may help to reduce the number of injections. However, there is no role for macular laser for CRVO related macular edema. However, pan-retinal laser, of course, is important for NVE, NVD, or NVI. So what is the follow-up evaluation for any RVO? It has to be every 6 to 12 months, even if they are asymptomatic. And every visit, especially in CRVO, requires an undilated slit lamp exam as well as gonioscopy. Look for glaucomatous disc which may have been missed or not present at the first visit. Look carefully for new vessels on the posterior segment. And very important, look at the fellow eye. Very often they have a silent RVO in the other eye. As you see, these are bilateral cases. And in the slides on the right, you see the other eye is asymptomatic. In fact, mostly they are asymptomatic. And they have a disease which can lead to proliferative retinopathy. In the young, there are certain features which are different. They are often related to inflammation, which often we do not find an etiology. Though there could be something like homocystinemia or an antiphospholipid syndrome, or they may be on oral contraceptive pills or sildenafil. So we should ask for the drug history in a young RVO. The prognosis in young RVO is very good. Generally, they are less symptomatic and one injection is usually enough. They do not require repeated injections. Thank you.
Thank you, Dr. Malika, for nicely summing up all the relevant points related to vein occlusions. And you very rightly highlighted the fact that these patients require annual examinations because they can come back with a vitreous hemorrhage much later after the acute episode. And you also highlighted the importance of a slit lamp examination to rule out neovascularization of the iris.
Yeah, gonioscopy. And we also need to treat it as like any stroke. So systemic examination need to be done in a thorough way. Rest all things she covered very well.
We just have a question, a quick answer to that.
Yeah.
That what are the systemic investigations that you would advise these patients, a patient with a VRVO or CRVO?
The usual, the CBP, blood sugar, serum lipid profile, homocysteine, that and blood pressure checking in the OPD itself, because most of them deny that they are in denial actually. They are mostly in denial. So that's all, not very extensive in elderly people. In younger people, we might look for antiphospholipid antibody syndrome. We may do an entire inflammatory profile for sarcoid, SLE, ANA. But
when blood disc ratios are very important in young. In adult, I do carotid Doppler also because atherosclerotic changes can happen in this, and that can be a reason for repeated attacks. Means it's not one BRVO. Certain times, multiple recurrence of BRVO can happen. So blood vascular occlusions, it's almost like 10% of the patient times there can be a second attack of BRVO or CRVO in a given same eye. So that should be ruled out.
And do you start these patients on blood thinners at the first dose, like
Yes,
aspirin?
very much required. And lipid lowering agents also. If there are any atherosclerotic changes and lipid profile is normal, still you start on lipid lowering agents.
Thank you. So we'll move on to our next talk, and that will be by Dr. Sachin Mahuli. He'll be giving his retinal pearls on artery occlusion. So Dr. Mahuli is the director of the Netra Darshan Super Specialty Eye Hospital at Belgaum. He also heads the Vitreoretina services at the Vision Multi Specialty Hospital at Mapsa, Goa. So over to you, Dr. Mahuli, for your pearls on retinal artery occlusion.
Thank you. Am I audible?
Yes,
Yeah.
yes. Very good.
Yeah, at the outset, I'd like to thank Dr. Tinku and the entire ARC team for having me here. So I'd like to share some clinical pearls on central retinal artery occlusion. Basically, this is a thromboembolic phenomena and a true emergency, and we need to have a very good systemic history along whenever we see these patients. Quickly, slides. Okay. Quickly, we'll look into why this central retinal artery occlusion is very important, because ophthalmic artery is the first branch of the ICA, internal carotid artery, and it has a very reasonably long course, up to 8 to 15 millimeter course behind the globe. So most of this is the area where it can get blocked. Ciliary retinal artery is present in around 20% of the population. It's very important. We'll come to that why it is important. So what is the clinical picture whenever patient presents to you with a monocular sudden loss of vision? vision varying from PL and a varying degree of vision. They can also complain of field loss. Sometimes they can come with amaurosis freakiacs that there will be sudden loss of vision and then they regain the vision after some time. But it will be very dramatic. Patients cannot miss it, and they'll definitely give this history. In very severe cases of, you can also notice RAPD. Clinically, you can see a cherry red spot, especially in cases where there is ciliary retinal arteries intact, and posterior pole whitening will be there in most of these cases. In very severe cases, there can be disc edema. If the patient presents later, there can be a disc pallor as well. So, in around 20 to 40% of these cases, you can actually see the embolus of the in the retinal artery. 20 to 40% of the cases, because this is the only artery which you can see live in our body. So these are the pictures where you can see these emboli either at the optic disc or in the periphery, or if it is migrated, or you can see silver wiring of the blood vessels, which is in very severe cases. This is a clinical picture. Very classically, you can see whitening of the posterior pole, and here the ciliary retinal artery is intact. The central part of the strip is still perfused very well. So how do we image these patients? Imaging has a very limited role in prognosticating or in diagnosis. Mainly, it is a clinical diagnosis. We don't have to spend too much time on imaging. Uh, However, fundus fluorescein angiography will tell us whether the ciliary retinal artery is intact, or looking at the perfusion of the macula, we can definitely prognosticate. OCT early pictures, you'll see a very hyperreflective, areas in acute phase. You can also see ILM detachment in later phases, wherein after 4 to 5 days, and in the very late phases, you can see a macular atrophy due to ischemic changes. So this is a very interesting article which I read by Ramesh Venkatesh et al. From Narayan Netralaya. They have documented the course of CRVO, how as the days pass by, how the ILM detachment happens and how it leads to an atrophic changes. How do we evaluate these cases? We this is a true emergency in ophthalmic OPD. You need to rule out giant cell arthritis also in patients who are above for 50 years of age, and they will very classically have a pain, temporal pain, and they'll have all the features of arthritis around the temple area. Carotid Doppler is a must in all these cases because you might find atherosclerotic plaques in most of these cases. Echocardiogram is also important because if there is a mobile plaque in the heart, can also lead to these type of uh, occlusions. Coagulation profile is a must in young patients, especially a serum homocysteine level or antiphospholipid, or for example, protein C or protein S may also be investigated for these patients, because young patients with such type of coagulopathy are also common nowadays, and we are also seeing without any reason post-COVID young patients coming with central retinal artery occlusions. Infective cause is very rare, but should be kept in mind. It could be a septic emboli, which can cause, picture of a CRAO. Very important is all these patients should be treated like a cerebrovascular accident or a stroke. You have to have a neuroreferral immediately, cardiac evaluation, because most of the cases will end up later or sooner. They will have to be evaluated for a stroke. And most common cause of patients who present with CRAO is a cardiac arrest. So you need to evaluate all these patients for that, and you have to give a prompt referral to neurology and a cardiology department. So coming to the presentations, it can be varied. It can present with a very classical CRAO, or it can be some sort of ocular ischemic syndrome. It can be combined with a vein occlusion, like in this picture you can see, it is a combined vein occlusion along with the central retinal artery occlusion. So what is important is once you diagnose these cases, we have a very short window for the treatment, and the treatment also is very controversial. Results vary with whatever treatment we plan. The ischemic cell injury usually is said that within 90 to 100 minutes, the irreversible damage occurs to the retinal cells. So the treatment window is very limited. A very good ocular massage. I have seen few cases in my own experience wherein a good digital massage or a massage with a Goldman 3 mirror, or you can also use a focal laser lens, area centralis lens, which you can put on the eye and give a massage. You can actually see the retinal artery pulsating, and you can see how the perfusion is improving to the optic disc. Some patients do, say that after the massage they have gained some, benefit. Not very common, but very early cases. Or if you can dislodge the clot by this massage, it's nothing like it. IV or oral estrazolamide, mannitol to lower the IOP, so that we want to, sort of decrease the IOP so that the clot is dislodged. Uh, Sublingual isosorbide dinitrate, AC paracentesis, anticoagulants, and antiplatelets should be started. Anticoagulants are not very commonly used, but antiplatelets we should start in all the patients. AC paracentesis also has a variable degree of success. By doing, again, the principle is the same. By doing AC paracentesis, you are trying to reduce the intraocular pressure so that you want to dislodge the clot. Hyperbaric oxygen also has been tried in few cases and few reports with variable results. Systemic steroids are indicated in genital arthritis. Few people have tried a YAG laser, single burst YAG laser to the emboli with varying degree of success. Intraoperative TPA, if you read the Eagle study, also they have tried. Some people have tried vitrectomy just to decompress by induction of PVD, just to decompress the globe from inside and keep it hypertonous so that the clot dislodges. So these are the various modes of treatment when we think of CRAO. What are the complications if ophthalmic artery is also involved? Then they can present with NVD, NVE, and later stages. Only CRAO can present with optic atrophy. NVG can be presented in cases with a severe ophthalmic artery occlusions. Systemic complications, MI. There is very high chances of these patients developing an MI, as high as 50% in the 9-year follow-up of these patients. They also have 30 to 40% risk of developing stroke in next 5 years. So all these are very important. So a prompt referral to a physician, to a neurologist, and the cardiologist is very important, because we are dealing with a systemic disease, which is a thromboembolic phenomena, which is presenting in the eye. Thank you very much. The topic was pretty small, so I could just brief it with it. Thank you so much.
Yeah, thank you, Dr. Mahuli, for highlighting the important systemic evaluation that needs to be done in these patients. So I'll go over to the chairpersons for some quick comments. Dr. Ajit Babu.
Yeah, I agree with Sachin, but it's unfortunate for him that the topic is a little bit tough actually, because there is no definitive treatment, that's proven treatment for CRAO. So he concentrated mostly on life saving. In that, one is 2D echo. It need to be done in all cases of CRAO.
Yeah.
Because myxoma is one of the very common cardiac condition that can lead to CRAOs. And giant cell arteritis must be ruled out. For that, he said temporal artery pain
Biopsy.
in the temporal biopsy, one thing. And more than that, simple thing is ESR. ESR
Yes,
should be monitored. Usually, giant cell arteritis ESR will be very raised, and that you should give the steroids, and there should be a demonstrable reduction of ESR. That is very essential in safeguarding these patients from bilateral involvement actually. The ocular treatments, I think everyone knows multitude means it is not very effective, except for vitrectomy claimed by someone in very early stage. Within 6 hours, they are claiming success.
Yeah, I think very well summarized, Dr. Babu. I think this RAO, retinal artery occlusion, is more importantly the situation where you need a combination of lipid lowering with antiplatelet agents. This should be given anyway, whether the patient's lipids are high or not, and this is for life, because as we know, it can increase the risk of stroke and MI also. So all these things up, and the other eye involvement. is reduced by use of lipid-lowering agent along with a antiplatelet. So that's very important. And while in an RVO, we may not do carotid scanning as well as not an echocardiogram, but those are the things which are added here. In addition to what we do for RVO is CBP, blood sugar,
Yes,
lipids,
yes.
and homocysteine. Here we add carotid scanning and echocardiogram, as Dr. Babu said. And we do put the patient on lipid lowering and antiplatelets if the physician is also approves it. With regard to treatment, actually, I think we do not give IV thrombolysis, but actually the American Heart Association recommends using IV TPA, intravenous. Of course, patient has to be admitted for possible intracranial hemorrhage, etc. But it does improve the outcome if it is started in the first few hours following a CRAO. Intravenous, not intra-arterial in the ophthalmic artery, because that the EAGLE study has actually found a lot of complications with that. So intravenous thrombolysis can be done, though we don't do it.
We have seen a couple of such patients who admitted to the hospital. And I have seen a patient of CRAO improving to 6/6 vision, no sign of the ischemia whatsoever after intra-arterial thrombolysis therapy.
Intravenous, you mean?
Yeah, intravenous therapy. So with that, we'll move on to the next talk. And our next speaker is Dr. Purnachandra B. So Dr. Purnachandra is a vitreoretina consultant and also a consultant in the electrophysiology department and the clinical genetics department at Narayan Nethralaya, Bangalore. And he's an expert in retinal dystrophies, and he'll be giving us some clinical pearls on how to diagnose and manage these patients.
So, good evening, everyone. At the outset, I would like to thank Tikubali ma'am and Prashant sir for this opportunity, and also my regards to all the panelists and more other speakers.
Your voice is coming very low, Purnachandra.
Is it better, sir, now?
No, I think you need to improve it some.
Okay. Now what I can do is maybe you can switch to the next
Yeah.
speaker.
This
I'll
is
change
better.
my audio. This
This
is
is
better?
better.
Just
Better.
come closer to your system.
No, I'm using headphones. Okay. I don't know. Okay. Fine. I mean, is it better now?
No, again, it's gone down. Maybe you speak louder. You can increase your volume.
So is it better, ma'am? Am I
No,
audible?
yeah,
Yes.
better.
Oh, okay, fine. Thank you so much, and sorry for the technical glitch. So I'll be covering clinical pulse in retinal dystrophies. One more group of disorders where there is no definitive treatment. So before going into the case example on the pulse, we need to understand something basic. We need to differentiate between what is a dystrophy and what is degeneration. We call AMD age-related macular degeneration, not age-related macular dystrophy. The reason being that dystrophies are inherited, non-inflammatory, early onset, bilateral, and most of the time they're quite symmetrical, whereas degeneration can be sporadic, usually late onset, unilateral, could be bilateral, and most of the time they could be asymmetrical. When it comes to retinal dystrophies, it can be classified in multiple ways, depending on the inheritance pattern as dominant and recessive, and we all know the definitions of it. I will not go into that. And there are some dystrophies which affects the peripheral retina, like retinitis pigmentosa, rod cone dystrophies, choroideremia, and gyrate atrophy, where quite central vision could be quite intact till the late stages of the disease. So let me begin with a case example. This was a case of a 29-year-old male who presented with a relatively good central vision of 6, 9, and 6, and he had night vision problem and history suggestive of tunnel vision. And when you see the fundus photograph, it's very classic. You see waxy pallor of the disc, attenuation of vessels, and multiple bone speckle-like pigmentation, which is a triad of retinitis pigmentosa. When we do an OCT, if you carefully observe, the ellipsoid zone is present only in the foveal region and it will be degenerate in the parafoveal region. That's the reason they have tunnel vision. And most of the time, I get a lot of requests for an ERG in these patients. Let's see what happens when you do a fulfilled ERG in this patient. If you look at the dark adapted responses, it's undetectable. And same with the light adapted responses, it is undetectable. So the reason being the photoreceptor which is present only in the foveal region are not enough to elicit a fulfilled ERG response. So if at all, if you want to monitor this patient for any study purpose or anything, you can do a pattern or a multifocal ERG. Otherwise, most of the time, your autofluorescence and OCT is enough to diagnose. In fact, before that, the clinical itself, it will be classic. But sometimes some patients with a similar symptom profile can have these kind of fundus picture, where you can see general attenuation, mild pallor after this, but there are no pigments in this. So these are the variants of RP. It's called, first one is the RP sign pigmentum, and the second one is the retinitis punctata albicans. In these cases where the features of retinal pigmentary changes are not very prominent, you can definitely do an autofluorescence as I mentioned. And OCT will always show classic parafoveal loss of photoreceptor. If you compare it to a normal OCT where the ellipsoid zone is present throughout, in patients with rod cone dystrophy group of disorders like retinitis pigmentosa, these are intact only in the foveal region and there will be tapering and loss in the parafoveal region. So second case, this is a 11-year-old male who presented blurred vision with a relatively good vision of 6/9. And when we draw the pedigree, we got to know a born out of a consanguineous marriage and had one more unaffected sister. So this was the fundus photograph and the corresponding autofluorescence, where you can see vitaliform deposits in the macular region, which is very classic of a Best disease. When you do an OCT, you will have subretinal fluid with vitaliform-like deposits, which can sometimes be, we can get confused with the CACR. But when you do an autofluorescence, as Dr. Neha was showing in her case example, the vitaliform deposits can be better highlighted. In case if there is confusion in diagnosis, you can definitely go for electrophysiological test, where if you do a fulfilled ERG, most of the time it will be a normal fulfilled ERG. And if you do an electrooculogram, which is very specific to the best group of disorders, because it happens due to a mutation in gene called bestrophin, which is localized to retinal pigment epithelium, and EOG indirectly it measures the functional integrity of retinal pigment epithelium. If you look at this EOG, there should be a bright face rise, which is absent here, which is an abnormal. So this is very classic of a dominant Best disease where the fulfilled ERG will be normal and EOG will be abnormal. And it's also important to screen the family members. So when you screen the family members, this is the proband who had a very classic Best disease. The father was also carrying the same mutation, but he was asymptomatic. But when we screened him in the left eye, you can see there is some amount of vitaliform deposits in the parafoveal region. Sometimes this disease could be as subtle like this and can be asymmetric also and can go against the definition of a dystrophy. So as I told, the proband was found to have heterozygous mutation in BEST1 gene because we know this is the autosomal dominant disease and the mutation will be heterozygous. So this is one of the most common Mendelian macular dystrophy and characterized by typical egg-like or vitaliform-like deposits, and 20% develop CNVM, and they go through multiple stages like pre-vitaliform stage, pseudohypopia, vitally atrophic stage, and finally atrophic stage. During any of these stage, patients can develop choroidal neovascular membrane, which is a secondary complication. So most of the time, the visual acuity is 20/20. It could be even better also. So the visual loss usually occurs because of secondary complications like nodular fibrosis or development of choroidal neovascular membranes. And these patients also tend to be hyperopes and have narrow angles. And it's important to screen these patients for glaucoma very often. So the second case is similar to first case, but slightly different. I'll let you know how different it is. This is a 26-year-old male who's born out of consanguineous marriage with a vision of 6/18 with narrow angles. This was the fundus and the fluorescent angiography picture. If you carefully look at the fundus picture, there's extensive vitaliform-like deposits, not only limited to the posterior pole as in the previous case. It is quite extensive beyond the arcades also. And if you look at the fundus fluorescent angiography, there is some non-specific leakage and staining. And this patient, before coming to me, was diagnosed as posterior uveitis elsewhere and was on all forms of immunosuppressant or steroids, antivirals, and all that. When you do an autofluorescence test, whatever the vitaliform deposit, what I showed in the fundus picture, which gets better highlighted on an autofluorescence. And if you look at the OCT, as opposed to the previous case, which had only subretinal fluid, there is an intraretinal fluid also. So this is a case of autosomal recessive bestrophinopathy. Again, the gene involved is same. The first patient had a heterozygous mutation. This patient, being a recessive disease, will have a homozygous mutation. When we do an ERG, they'll be grossly abnormal. So when we do an EOG, it will be almost undetectable because we have a homozygous mutation with literally no functional bestrophin protein. So as expected, when we did a genetic testing, this patient had a homozygous mutation in BEST1 gene. The unaffected sibling had normal and parents were heterozygous carriers. And again, as I told in the best disease, whenever you diagnose these things, always to better label this as a dystrophy than being misdiagnosed as post-uveitis and putting them on different therapies. And these patients also, have a tendency of developing choroidal neovascular membrane, especially when a very trivial trauma can elicit this because the Brooks membrane in these patients will be very brittle. So even a subtle trauma can cause a break in Brooks membrane, giving rise to choroidal neovascular membrane. So they should be cautioned against playing a contact sports and protective eyewear. And these are also patients are also prone for angle closure glaucomas. And in fact, most of my patients in my cohort, I've seen them losing vision to glaucoma than the dystrophy per se. Fine. So the next case in the pearl is this is a 10-year-old female with a vision of 6/60, had atrophic macular changes in the fundus examination. It was better highlighted when we do an autofluorescence test. You can see the atrophy in the macular region with multiple flex-like deposits which are distributed throughout. The atrophy is confirmed when you do an OCT, which shows foveal thinning with outer retinal loss and also an RP atrophy. So as we all know, this is a very classic case of Stargardt disease, which presents with macular atrophy in flex-like disease. When we did an ERG in this patient, if you see that there is a cone rod dysfunction, the dark adapted responses are also affected and the light adapted responses are also affected. So now you may ask why we should do an ERG in this patient as there is no treatment. So in Stargardt group of disorders, ERG to an extent can help us to prognosticate. There are three types of Stargardts. In type 1, in which the fulfilled ERG could be normal, in which case the disease is limited to the macula and the chances of progression is minimal. If only cones are affected, there's a 20% chance of progression. If both cones and rods are affected, as in our case, there's an 80% chance of progression. Because this is very important because this is the next question what patient is asked once you diagnose the dystrophy. Will it is it going to get worse or is it going to remain stationary? So the ERG to an extent helps to prognosticate. This patient had homozygous mutation ABCA4 gene, which is known to cause Stargardts, which is relatively good thing compared to other dystrophies because there are a lot of clinical trials which are ongoing when it comes to ABCA4 gene. So basically, this disease happens due to deposition of A2E bisretinoid, which is a major component of lipofuscin. So if you look at this cartoon, so depending on the functionality of ABCA4, if the ABCA4 gene is fully functional, you can have a normal appearing fundus with a normal ERG. If it is partially functional, you can have Stargardt-like presentation. If it is severely affected the function, the patients can present like retinitis pigmentosa also. So this is very important. The gene could be same, the clinical presentation could be different. So the clinically, it may have normal or non-specific mottling at the fovea. It can have a foveal atrophy with a classic textbook description of beaten bronze appearance or varying degree of yellow-white flecks and can also have bullseye configuration. So management, currently there is no treatment. There are many ongoing trials, both in terms of gene therapy and also visual cycle inhibitors. We should give them low vision aids and we should give them dark glasses. It's very important. They should, protect themselves against the bright light. They can wear caps because the more and more we stimulate the visual cycle, there's a more chance of this retinol getting deposit leading to further degeneration. And most importantly, please avoid giving any form of vitamin A and A-rate supplementation to reduce the bisretinoid formation. So that is something very important. In fact, in the diet also, we should advise them, not to, the fact that the patient, the moment we, diagnose them and tell them that there is a problem in the eye, they have a tendency of eating a lot of carrots, fish and all that. That should be avoided in Stargardt group of disorders. So the last two cases, I have two more cases. This was a 22-year-old male who presented with diminution of vision. He also had a photophobia. The fundus clinically appeared normal. Basically, he was referred to me thinking that maybe he was malingering. So, but when you did an autofluorescence, there was a very subtle change in the foveal region. When we did an OCT, there was a subfoveal cavitation which can be seen, which resembled a photic retinopathy, which happens when we get exposed to bright light or any welding arc or eclipse, right? But when we did an ERG, if you look at the dark adapted responses, it was completely normal. The light adapted responses are undetectable. So, though the defect is seen only in the foveolar region, the ERG is suggesting the cones in the entire retina are non-functional. So, this is a case of achromatopsia, which is a form of stationary cone dystrophy, because cone dystrophy can be early onset stationary or late onset progressive. Our patient falls into the early onset stationary, which is good for the patient because he's born like that, he's going to live like that, and is not going to progress. So the last case, so this was a story of a 37-year-old male who presented with blurring of vision with relatively good vision in the right eye and a 6/24 vision in the left eye. So fundus examination, if you carefully look at the foveola, there is a very early onset bullseye maculopathy. So the atrophic changes gets better highlighted when you do a multicolor and an autofluorescence image. And OCT is also showing foveal atrophy in both eyes. So he basically came to us. He knew the diagnosis that he's having some dystrophy. Basically, he came to us because he was interested in family planning. He wanted to know the chances of his progeny getting affected. When he came, the wife was already 6 weeks pregnant. When we did a fulfilled DRG, which was relatively okay, the prognosis for the patient is good. When we did a genetic testing, the father had a compound heterozygous mutation in ABCA4 gene. That means two mutation on the same gene. The mother, that means the wife, was totally unrelated, was also carrying one of the mutation in the recessive state. When we did an amniocentesis, unfortunately, the fetus was found to be carrying these two genes in a compound heterozygous state. That is, it is affected. In these scenarios, you should need to communicate to the obstetrician and also discuss with the patient to how to proceed about it, because we cannot right away advise it abortion and all that. It finally the family who have to take a call. We can only tell us about the probabilities and the disease incident, the severity and all that. Finally, they will have to take the call. So to conclude, I would like to say that with the advent of better genetic testing, the proper diagnosis is very important, because we should not, mislabel a treatable condition as retinal dystrophy and vice versa, and treat a retinal dystrophy as because of the other masquerades. So it definitely helps patients to make better choices, better understand the prognosis, and also to know what future holds for them. If any of you have come across any patient of dystrophy where there's a confusion, if you need any help in terms of genetic counseling, diagnosis, family planning, and the future prospects of gene therapy, definitely you all can get in touch with us. And thank you so much.
Thank you, Dr. Purna Chandra, for those very insightful case scenarios that you presented. We have a lot of questions asking that what should an ophthalmologist prescribe to a patient of retinitis pigmentosa? Or what are the do's and don'ts that you would tell to such a patient? How would you counsel such a patient? What would you prescribe? Very
So
quickly.
for retinitis pigmentosa, diagnostic clues I've already shared. I won't go into that. And first of all, there's no treatment. Regarding vitamin A supplementation, most of the what they do is we have now enough evidence it has not got any role in that. So because it is as simple as that. This is genetic, there is a defect in some gene, unless until you correct that gene, it is not going to help. So that is one thing. First instance only, you have to make it very clear, because we don't want to keep patients under false hope that there is a night vision, you take vitamin A, it will get better. And after 2 years, they will present with progression and they will tell you you gave tablets but still progress. And also in some of the genes, the supplementation can worsen the disease. So that is one thing which has to be kept in mind. And the second thing is, more importantly, to counsel them about their limitations, especially in RP. I have patients of RP who are professional drivers like cab drivers and all that. वो टेल अरे सर रात को थोड़ा प्रॉब्लम होता है मैं चला लेता हूँ. That's extremely important. You need to counsel them and make them realize what are the limitations, what are the do's and don'ts, lifestyle modification. And if you have a facility, please refer them to a visual rehabilitation who can definitely guide them and counsel them to increase the quality of life. And the other thing is definitely genetic counseling. So what you can tell is you can just tell them you get a genetic testing done. So that is one thing. Definitely, it will help us to know the future, the inheritance pattern, the family planning, and all. Other than that, it also helps us to keep a track of research. You can tell them if you go to Google and type retinitis pigmentosa, you can get many things which may not be relevant to your condition. Once you know the genetic testing, just type that gene, you'll get information which is relevant to that. So that is one thing. And there are some gene independent approaches which are there. I don't think I can go into details of it. So when you start on supplement, you have to be careful which gene you are dealing with. In RP group of disorders, supplementing them with this kind of curcumin product, resveratrol, saffron, and all that, they seem to have some amount of at research level at animal studies some benefits in this thing. But you have to be very careful about which gene are dealing. If you have a gene of ABCA4 which is presenting like ABCA4, definitely don't supplement. If you are sure at this point of time, based on the present day, this is 16th May 2025. If it's not ABCA4, you can give supplements. It may not harm, but tell them frankly that this is just a supportive therapy may not help them. That is in brief. Sorry, I mean, there are so many things which I can.
I know, it's a very vast
Yeah,
topic.
yeah.
So,
Yeah.
chairpersons, anything to add before we move on to the next topic? We'll move on.
What most of the ophthalmologists do wrong is they state that there is no treatment. That is the problem. First of all, assess what stage they are and how to handle their life and rest of the lifestyle, and that is one thing that counseling need to be done. Second, family counseling. Genetic counseling is very essential for retinitis pigmentosa. But rest of the retinal dystrophies, they can typify. They are not so dangerous diseases. So once you identify the exact retinal dystrophy, you can prognosticate that, and the whole life can be led happily without losing much sight, except for RP cases. So that should be sent across to all the ophthalmologists. They should know, and he has shown, Purnchandra has shown very beautiful pictures. Multimodal imaging is very essential to arrive at the final diagnosis in these retinal dystrophies, and that need to be done.
Thank you.
Yeah, in young people, especially speaking very bluntly in front of the patient that nothing can be done is very dangerous. They can even try to commit suicide. So when it's a very young person, even a child, it's better to send them out when talking to the parents about the future, because young minds cannot take the diagnosis. Other thing I was interested to know if you have any time referred for gene therapy, the Luxturna in Stargardt's, if you had an RPE65 kind of gene defect.
Luxturna, we have not tried in our cohort in India, but I have experience of interacting with the investigator who are part of the trial. So basically, this is for RPE65 mediated Libus congenital amaurosis. If you treat them early, like for example, who are in the first decade, definitely their quality of life is better. Definitely better. But it's one-time treatment. I mean, cost factor, all of us know I cannot go. I mean, keeping the cost factor aside, if you have a patient of health presenting like an LCA phenotype, because RP65 sometimes can cause RP-like phenotype also. LCA, if you treat them early, where there are still viable photoreceptor and retinal pigment epithelial cells, definitely it can offer some benefit. We have seen them, big change in their lifestyle, because they need not become 6'6". If they become from PL to CFCF also, it need not be Snellen improvement also. Sometimes there could be other forms of improvement, which makes big difference for them.
Yeah.
So it does work. It does work. I don't have first hand experience. Yeah.
Even in a subcategory of retinitis pigmentosa, not just LCA, but also RP, with RP65 genetic defect.
RP65, the patient who present with typical RP-like phenotype with the intact macula and all. So for them, there is not much of a data available for an RP65 this thing, because when they present these kind of phenotypes, sometimes they doubt the RP65, even though it comes as a pathogenic. We need to revisit the diagnosis because it's extremely rare. Because if you look at the way the RP65, the gene, the functions, the classic thing is when you do an autofluorescence, there should not be an autofluorescence signal. It is that severe. So if you have an RP patient with RP60 first itself, there could be doubt. And the second thing is in patients who have an intact macula in these patients, I'll be little skeptical to subject them because, the subretinal delivery itself has many surgical complications which have been, reported while raising the blood. The only surviving phobia in choroideremia and RP have been atrophied and all that. I'll be a little skeptical, whereas in LCA, we got nothing to do because again, selecting this patient for gene therapy is a very different thing because we do have a lot of patients coming and asking for this RP65. If they are affordable, if they're in first decade, if it's a classic LCA phenotype, I'll strongly recommend.
Thank you.
Yes.
Thank you, Dr. Purna Chandra. So you gave some great insights into retinal dystrophies. And with that, we move on to our next talk. That will be by Dr. Atul Dhawan. So Dr. Dhawan is the medical director of the ASG Eye Hospital at Kanpur. He is also the founder and administrator of a very popular retina interest WhatsApp group called Our World. So over to you, Dr. Dhawan, and look forward to your clinical pearls in epiretinal membrane and macular holes.
CRC for this opportunity. Today I'm going to talk about the epiretinal membrane and the macula hole. Both the cases I'll talk about the same line. What is the disease, how to find out the disease, what is the diagnosis, and how to go for the management. So this is the normal retina, and this normal retina start from the RP and go till the ILM. If any layer over this ILM, that is called as the epiretinal membrane. Now, what is epiretinal membrane? Epiretinal membrane is cellular proliferation on the surface of the retina. This membrane, which is hyperreflective on the surface of the retina, is called as the epiretinal membrane. The prevalence is 7 to 12%. That means all the epiretinal membrane which are coming, that is not for the operation. Most of the cases, they are just incidental finding. And the idiopathic cases of ERM is bilateral in 20 to 30% of the cases. Now, what is the classification of this? How this is of two types, whether it is associated with some abnormality or not, based on. So if it is associated with some abnormality, then it is called as the secondary ERM. If it is not associated, it is called as idiopathic ERM. Most of the secondary ERM are associated with vascular occlusion like BRVO, CRVO, diabetes, trauma, inflammation, uveitis, retinal detachment, either pre-op or the post-op, hematoma, and rest of and many other cases. Now, how the patient comes to you? The patient comes to you with the two main problems. One is the central visual loss, and the second one is the metamorphopsia. The patient complains you about that he or she is not able to see from the last 1 year or 2 years, and the vision is deteriorating slowly. So, and if the patient is a literate and more into the studies, he can tell you that the letters are zigzag when he is reading the newspaper. So you don't have to ask from yourself. The patient will tell you the complaint. Now, what are the stages of this membrane? They have divided into the 3 stages. One is the 0, one is the 1, the other one is the 1, and the last one is the grade 2. In the grade 0, there is a cellophane maculopathy. It is totally asymptomatic, incidental finding. The patient is coming to you for the cataract surgery. You have seen a transparent membrane over the retina, no abnormality, no distortion of the retina, no distortion of the blood vessel. So nothing, it requires nothing. Now, grade 1, in this irregular wrinkling of the retina is present, And not more than that, you can see the blood vessels behind this. Here, a very thin membrane is there. You can see the blood vessel behind the membrane. The OCT of this is blunting of the foveal contour is there. A very thin membrane over this on the inner surface, and this is called as grade 1. Usually the vision is very good, so no need to touch this type of cases. The third one is grade 2 ERM. In this, opaque membrane is there. Obscuration of the underlying vessel is there. You cannot see the blood vessel behind the membrane, and full thickness retinal distortion with or without this intraretinal cyst. This cyst is there because this traction causes breakdown of the blood retinal barrier and lead to the leakage. Now, what is the pathology? The pathology is, it is composed of two components. One is the matrix, extracellular matrix. The other one is the cell. The extracellular matrix is laminin, collagen, and fibronectin. Cells are of two types. One is retinal, one is the outer retina. One is the cells other than the retina. The cells from the retina is mainly the molar cell and the RP. The cells outside the retina is immune cells and the fibrocytes. Now, in the pathology, the ERM can form with or without PVT. In both the cases, the traction of the anomalous vitreous cause the pulling of molar cell, which comes over the surface of the retina and form the ERM. Grade 2 ERM cause the traction, which lead to the distortion, which you can see on the 78 diopter or 90 diopter examination. Cyst formation because of the blood retinal barrier breakage. Now, what is the how you can make the diagnosis? It is very easy. Only on the OCT. You require only the OCT, no FFN, nothing. So on the surface of the retina, you can see a hyperreflecting membrane, the usual foveal contour lost, the corrugation on the inner surface of the retina is there, and increased thickness of the retina because of this contraction of this membrane. There is thickness of the retina increases. The cyst formation is there because of the breakdown of the blood retinal barrier. Now, what is the treatment? The treatment is start during the talk with the patient. Never ask, never give any clue to any patient. Just ask what you are suffering from, because most of the time it is asymptomatic. Let the patient tell you what is the problem. So the treatment is only surgical, which we usually do at around 6/18 or less vision. Don't operate very early, 6/6 or 6/9 vision, because this is a very slow growing process. Do the core vitrectomy, stain the posterior highlight with IVTA, do PVD induction, stain the membrane with the brilliant blue, and remove the ERM plus minus ILM. Now, this is a small video of surgery. This is the ERM. Just hold it with the ILM grasping forceps. Remove it from the surface of the retina. Just go the forceps near the retinal surface. By this, you can take it out in a single piece. If there is any adherence is there, leave it that side, start from the other side, and go to this adherence side at the last point. It will come out very easily. Now, this is a case in which I have operated a couple of months back. The hyperreflective layer is there. Pre-op 6/18 was there, and post-op 2 months 6/9 was there. Always remember, this is not a macular hole surgery where the vision will improve in the first month or first week or second week. The vision usually improves after 3, 4, 6 months. So tell the patient that the visual recovery will not be so fast. The complication is cataract in most of the cases. So usually we combine, if the patient is more than 50, 55 years, so combine the surgery with the cataract surgery. RD surgery because during the PVD induction, it's very less, around 4 to 5%. The second one is the macular hole. Now I'll take it in a question answer session. Is the first question is it the resting stage of the fovea? No, it is not the resting stage of the fovea. Centripetal and the centrifugal forces are there. In this case, the centripetal means that forces towards the center are more than the centrifugal forces. Fugal means away from the center. So the retina is towards the center. The central force is by the foveal cone Muller cell, which is acting like a Fevicol. How the FTMH formed? Very simple. Because of the anomalous PVD, the vitreous is pulling the retina at the center. It forms the foveal pseudocyst, and later on, it causes the full thickness macular hole. In a real world scenario, this patient come to me in August 2024 with VMTS grade 2, 6/9 vision, nothing was advised. Then October, it increases to stage 1B macular hole. Then November, full thickness macular hole. Then February, again patient came with a stage 2 macular hole. You can see the vitreous is still there and full thickness macular hole is there. So I have operated the case, and how I have preserved this operculum, and I have put this operculum as a ILM flap, and after 1 week, this you can see the hole closure is there, and after 1 month of post-op, the hole closure, U-shaped hole closure is there. The vision improved from 660 to 612. Now the question is, when any cut is there in the body try to heal itself. Body is a supercomputer. So why not there is a spontaneous healing of macular hole? Yes, spontaneous healing of macular hole is there. Most of the hole we are seeing, they are not able to close spontaneously. Otherwise, what happens whenever there is a macular hole, these foveal cone Muller cell comes to center part, form a bridge and lead to the centripetal migration of the other cell and hole closure. Now the question arises, why not all the hole closes spontaneously? 3 reasons are there. The hole is so large so that the approximation of the inner cell of FTMH is not possible. The other one is the centrifugal force. Centrifugal means ILM ERM forces which are pulling away from the center of the retina. They are more than the centripetal force. The third one is combination of both. So how can we help the retina as a best friend? Remove the tangential traction and close the hole artificially. I am doing only the ILM peeling, macular massage and ILM flap, not the amniotic membrane and retinal tissue transplant. So this is a small video. This is a live surgery. This was a live surgery directly recorded from the TV. It's a small macular hole. So I'm doing the ILM peeling, obliquely holding the ILM forceps, pulling it in a circumferential manner, taking out the ILM to remove the tangential traction over the hole. So the key point in the surgery is, if any hole, tear or lattice is present, do the laser and wait 2 weeks for the surgery. Induce the PVD till the posterior marking of the laser, and after that only trim the vitreous over the weak area. Don't do the PVD. Do the PVD till it is possible easily. Don't do it forcibly, otherwise you will make a break near the aura. Do the core vitrectomy Stay in the posterior highlight with the triamcinolone. Increase the magnification. This is most important. Increase the magnification. Hold the posterior highlight at the margin of the disc and separate very slowly. Now, stay in the ILM under fluid of air for 30 to 60 seconds. Inject this, the 6 point is also very important. Inject the dye drop by drop over the light probe, not directly over the retina, to prevent the dye going directly inside the hole or doing the iatrogenic tear formation. Do the ILM peeling under high magnification. I do it Zeiss microscope 1.6. Hold the forceps obliquely so you can see easily. Grasp the ILM 2-3 attempts, not one attempt. Otherwise, chances are there that you will hit the NFL. ILM flap surgery make a large temporal flap because you want to keep the flap over the hole till the end of the surgery and after that also. So the loss of the flap is less in the large hole. Do FAX superior to inferior to decrease the turbulence. 20% SF6 gas injection and prone position 4 to 5 hours inside the hospital. Thank you.
Thank you, Dr. Dhawan. Thank you for a very concise talk. So to the chairpersons, I would like to ask, what is your take on lamellar holes? What do you advise these patients? Should they go in for
Observation.
surgery? Okay.
You know that.
It
Usually,
depends on the-
if the vision is good, even a macular hole with 6/6 vision, I would not attempt surgery. I will wait for the vision to come down. Actually, a macular hole cannot be 6/6, but certain times it can happen when there is a small eccentric hole, full thickness macular hole. It's better to observe because patient need to appreciate that his vision is fallen down before operating.
Even with large macular holes, sometimes I have seen vision as good as N6, near vision at least.
Yeah.
And patient is happy with their vision, so we should be very careful touching those eyes. With regard to lamellar hole, Dr. Tinku, it would depend. We would follow them up like an ERM case. And if the vision starts deteriorating, there is distortion of images,
Obvious.
then we do operate. So lamellar also. And all, if it is an outer lamellar kind of picture, kind of foveal detachment, that needs surgery because it becomes in full thickness very fast. So there you do a fovea sparing ILM peeling in a stage B or stage 2 macular hole, which is also called foveal detachment.
Yeah, one of the macular holes which progressed over follow-up, at initial stages you would have intervened, Atul. That 3-4 months it has progressed to vitreous traction worsening and it's gone to full thickness.
Yes, sir. It started from the stage 2 VMTS to stage 3 VMTS.
At that stage only you would have intervened. So the visual outcome would be better in that case.
Yes, sir. But because patient was coming and patient was not ready to go for the surgery like that.
Okay, yeah. There are other factors which are beyond our control. Okay.
Yeah, Dr. Dhawan, I request you to just stop sharing your slides.
Also important to inform the patient before surgery the risk of retina detachment. That comes as a shock to them. We may tell them that vision will not improve. It may remain the same or it may little bit worsen also. We may tell them that, but do we tell them that they may lose the vision completely and that they should be ready for a resurgery to get back any vision? So that's very important to inform the risk of RD when we are counseling for macular surgery.
Very right. So with that, we move on to our final talk of the session. And this talk will be Pearls in Retinal Vasculitis by Dr. Pooja Sinha. So Dr. Pooja Sinha is a prolific vitreoretina surgeon, and she's also heading the retina services at the AB Eye Institute, Patna. So she's been very actively teaching young ophthalmologists, especially how to do indirect ophthalmoscopy. And I request her now to share her pearls in retinal vasculitis. Dr. Pooja Sinha.
Thank you, Dr. Tinku. A very good evening to everyone. And I'm very thankful to the academic team of ARC, as well as especially to Dr. Tinku for this opportunity. We were in the same school together in Lucknow. She was my senior in Loreto, and we have very fond memories. So going on to my topic of retinal vasculitis. So by definition, retinal vasculitis is inflammation of the retinal vessels resulting in clinical manifestations, that is vascular sheathing, leakage, and occlusion. The causes can be divided into infectious, systemic, neurological, malignancy-related, or idiopathic. So there are a whole list of infectious disorders, but I will be just highlighting a few. So the bacterial disorders could be tuberculosis, syphilis, viral disorders, cytomegalovirus, herpes simplex, herpes zoster, the HIV syndrome, parasitic disorders, and rare rickettsial disorders. Going on to the systemic disorders, there could be sarcoidosis, SLE, Behçet's disease, PAN, rheumatoid arthritis, etc. And the other causes of retinal vasculitis are neurological disorders, malignancy, or idiopathic, most commonly Eales disease. So the patient could be asymptomatic when only the peripheral retina is involved. There are peripheral retinal vasculitis changes, but they don't involve the vitreous or the macula. So the patient can just be asymptomatic. Symptomatic patients present with a rapid decrease in vision, implying that the macula is involved, or they could be floaters because of inflammation of the retinal blood vessels or vitreous hemorrhage. Sometimes the patient can complain of dark spots in the visual field or the scotomas. So this is the stage of retinal vasculitis where we have the active stage, where you can see this perivenular sheathing with the tortuosity of the vessels, with the multiple hemorrhages. This could lead on to the state of occlusion, where you see these ghost vessels. And at this stage, there is a lot of ischemia, which can be picked up if an FFA is done at this stage. Then you have the stage of neovascularization, when you have the NVD or the NVE. And this, obviously, when these tribal blood vessels bleed, you have the stage of complications, where there's vitreous hemorrhage, or when they extend anteriorly, you could have rubeosis iridis. So this is the classical picture of retinal vasculitis, where you see this perivenular sheathing with hemorrhages. So disorders associated with periphlebotitis could be tuberculosis, sarcoidosis, Behçet's, HIV, Eales disease. This is a very busy slide, but I'll be just highlighting the basic important things. In tuberculosis, you have a focal, multifocal, or a serpiginous choroiditis. And the retinal vasculitis is frequently ischemic in nature and may lead to vascular retinopathy. So this is the picture of tuberculosis vasculitis, where you have perivenous sheathing with exudates and superficial hemorrhages. And also commonly, you can see this fundus picture with a choroidal granuloma. Sarcoidosis, there is anterior granulomatous uveitis, and the retinal periphlebitis is basically non-occlusive, associated with segmental cuffing or a candle wax drippings. This is very pathognomic of sarcoidosis. So you can see this picture over here, which manifests the same. Behçet's disease, it's a recurrent occlusive vasculopathy, and there is bilateral non-granulomatous panuveitis with retinal vasculitis as the common clinical manifestation. And this is the classical fern-like pattern of vasculitis with hemorrhages. Eales disease is very commonly seen. It's an idiopathic inflammatory venous occlusive disease of young adult males. There are 3 hallmark signs, being retinal phlebitis, peripheral non-perfusion, and retinal neovascularization when there is ischemia. The pathognomic feature of vitritis and uveitis is absent. Toxoplasmosis, we all know it's the hallmark is focal necrotizing retinitis caused by Toxoplasma gondii. And the most important feature is headlight in the fog appearance, because there is severe vitritis. And as has been highlighted earlier in the stalk, is there's reactivation near an old scar. So this is the headlight in the fog appearance on the left-hand side, and on the right-hand side, you have a healed Toxoplasma scar. So how do we diagnose retinal vasculitis? The most important diagnosis is clinically, and also FFA could be a very important tool. The active stages shows leakage of dye from the inflamed vessel and vessel wall staining. Sometimes clinically not apparent vessel involvement can be seen through an FFA, and cystoid macular edema, capillary non-perfusion areas, NV and NVD can be picked up with an FFA, and this warrants treatment along with laser photocoagulation to treat the non-perfusion areas. So this is the patient history, as has been reiterated earlier. History is very important to diagnose patients of uveitis and vasculitis. So all these symptoms have to be asked. This is an exhaustive list of lab investigations, but we have to be prudent in selecting what we want to investigate based on the clinical findings that we see. So treatment, step ladder approach to treat retinal vasculitis is, first you have to rule out the infectious cause. If it's an infectious cause, it is obvious that you have to treat with a specific agent. Now coming on to the non-infectious causes, if the vision is good, if there is no CME, if there is no capillary dropout, just observe these patients. Treatment is indicated if there is obviously the vitreous is involved or there is macular edema as evident on OCT. And non-infectious causes are prudently treated with corticosteroids. They could be periocular or systemic. And if they're resistant to steroids, then immunosuppressives have to be used. Steroids are the mainstay. Start with a high dose of corticosteroids and taper according to the clinical response. And these are the steroid implants, the Ozurdex, the Retisert, and the Iluvien, which are most commonly used. So this is a case that I just recently encountered. The fundus picture showed periphlebitis as well as retinal vasculitis in the inferior arcade with hemorrhages, an area of retinal whitening showing some kind of artery occlusion also superior to the macula, and some fibrin dripping from the macula. And I just wanted to highlight that only with systemic steroids, the edema came down because there was also inflammation of the inner retinal vessels. The edema came down and the subretinal fluid also disappeared. And after the active inflammation stage had passed, then I treated the patient with a sectoral laser. So this is how the fundus picture looked. And then I treated the patient with the sectoral laser to alleviate the CNP areas. So this is the patient. So the complications which require surgical intervention are very commonly vitreous hemorrhage, which is non-resolving, a neovascular glaucoma or a TRD has to be treated surgically when medical management fails. So in conclusion, retinal vasculitis is often associated with lethal systemic diseases, so requires a multi-specialty approach to diagnosis and management. Steroids form the backbone of treatment, especially in non-infectious cases, and when the infection is met with, steroids are the backbone. Immunomodulation and cytotoxic drugs are second and third line agents. Imaging techniques like FFA, OCT, and fundus photography should be employed for better documentation and disease follow-up. And surgery is indicated when a stage of complication like vitreous hemorrhage and RD occur. Thank you so much for your patient hearing.
Thank you, Dr. Sinha, for nicely, very concisely summarizing this very vast and exhaustive topic. So we'll move over to the chairpersons for any inputs that they may have. Dr.
Mallika. Yeah.
Yeah, so you give me the hard topics, okay. Yeah, retinal vasculitis is should not be taken lightly. When we first see a patient with retinal vasculitis, we should be aware that it can be a blinding disease because of its potential for causing non-perfusion and proliferative retinopathy. Very often they may go, despite our treatment, they can go into retinal detachments. So we have to be very vigilant and start investigating very thoroughly right in the beginning, including, as you said, for Behçet's, for TB, the complete panel of investigations for sarcoid, SLE should be done in the first visit itself, so that we are not found left, we are not found lagging in treatment. And very often they need anti-TB treatment. They do not resolve without it. Sometimes they need biologics for control. So we have to be very careful, not underestimate or underestimate the seriousness of the disease.
Yeah. So Yeah, she very well highlighted that apart from the inflammatory component, the occlusive component also needs to be treated, and these patients require a long-term follow-up because those new
Not only
vessels
that,
come in
it is
later.
she highlighted much about the infective retinal vasculitis, but there are several reasons for non-infective retinal vasculitis, which may require steroid therapy and biologics in very controlled way for a long term, so that we should not have a complications. And intervention, as Malika said, the patient can worsen like anything in very short time. So very close follow-ups are very much required. And certain stages of retinal vasculitis, you need to differentiate whether the vasculitis is active or it has gone into quiescence. That is also important.
And every time bilateral examination is important. Sometimes they start with one eye
Yes.
and the other eye also starts becoming serious. If you're not looking for it, you may miss the proliferation as well. And sometimes the vasculitis goes away, but you are left with the sequelae like cystoid macular edema, which you will have to deal with for years. The vasculitis goes away, but somehow you have the sequelae of. And nowadays, there is to keep in mind a possibility of brolucizumab related retinal vasculitis as well. So we had a patient of occlusive retinal vasculitis, and the history showed that she had received brolucizumab, and so that's also to be kept in mind.
So thank you.
Okay. Yeah.
Yeah,
Post-COVID also, we were seeing a lot of cases of
Yes, yes,
retinal
yes.
vasculitis. So that
Yeah.
was also
Post-COVID occlusive vasculitis. Yes. Tinku, over to Tinku.
Yeah. So thank you.
Well,
I think we already passed the prescribed time. So thanks. Some great pearls were shared, great knowledge, and I thank all the speakers for their wonderful talks. I'm sure the ophthalmologist, everyone who's attending, has gone back with a virtual treasure trove of pearls. And equally thankful to our chairpersons, Dr. Ajit Babu Maji and Dr. Malika Goyal, for so patiently, being with us right till the end of the webinar and giving your very astute inputs. Thank you so much. So once again, very grateful to the presenters and the chairpersons and to the audience who's been with us and has been actively asking questions.
thank you very much for this
Thank you.
opportunity.
thank you.
Thank you so
Thank you very
much.
much. Thanks
Thank you.
to
Wish you a
everyone.
very good
Very
night.
good.
Okay, good night.
Thank you, ma'am. Thank you.
Thank you. And do watch out for the other ARC presentations. And for people who would like to go back and watch a certain segment, this will be there in the AIOS YouTube channel. So you can always go back and see this